Dinesh has come. Hi, Dinesh. How are you?
Hi, I'm fine. How are you?
Hi, Dinesh.
Everyone. Hi, Praveen. How are you?
Good.
Good evening, Dinesh.
Hi, good evening, sir. Good evening.
Recording in progress.
Yeah, 1 second. We are going to start. Reason is we are just waiting for people to come in.
Hi, Kumar. How are you?
Sir, good evening, sir. How are you, sir?
I'm fine.
Uh,
So, how is COVID in your in
sir,
Hassan?
COVID is less, sir. I think you have a lot of cases of COVID, sir, right now.
It's now coming down, slowly coming down. We did have a lot of cases, but slowly coming down.
We have started a lot of MISC right now
Now we're seeing MIC. Yeah.
because in Delhi it came down faster.
Hi,
Good evening,
Dr.
sir, Dinesh sir, Santosh sir.
Hello.
Good evening,
Hello.
Basav. How are you?
Yeah, fine, sir, fine.
Sir,
We are
good evening, sir.
getting
Basaraj, sir.
2 to 3 cases every day missing, sir, in our
Yeah.
ICH.
cases.
Missy, eh?
Yes, sir.
Yeah.
And also one of the thing what is changed from first wave to this second wave with the Missy is cardiac affection is a much more, sir.
Right.
I think I will see more of them in I think the whole month we'll see a lot more.
No,
Next
in the
month will be the MISC.
Yeah, in the first wave, we did not lose any Missy cases, but in the second wave, in the beginning itself, yesterday I lost one baby of 13-year-old.
Oh God.
Now, good evening, everybody, sir.
Yeah, good evening, Sudeep.
Hi.
Good evening.
Good evening, Sudhir, sir.
Good evening, sir.
Hey, Panak.
Good
Sir,
evening, Doctor, sir.
we'll wait for another 2 minutes, Sudhir, sir.
Yes, sir.
Now, 7:05 we will start introduction.
Yeah, we can start.
Hello, Kumar.
Sir,
Yeah.
good evening, sir. Kottresh, sir. I'm
good
doing
evening.
well, sir. How are you, sir?
Fine. This corona, we don't know how to do this thing, sir. And we are doing our job, and we are doing the best job. And the things, how we can go for this one, we also don't know. How is the situation at your place? Can you hear? ಕೇಳುತ್ತಾ
Kumar,
Unmute.
ಕೇಳ್ತದೆ ಸರ್.
ಕೇಳಿಸ್ತಾ ಇದೆ ಕೊಟ್ಟರೇಶ್ ಸರ್, ಹೇಳಿ ಸರ್.
ಹೆಂಗಿದೆ ಸಿಚುವೇಶನ್ ಎಲ್ಲ?
ಇನ್ನು ಕೇಸಸ್ ಕಮ್ಮಿನೇ ಆಗಿಲ್ಲ ಸರ್. ನಮ್ದು ಇನ್ನೂ
ಥರ್ಡ್ ವೇವ್ ಸಲಹೆ ಮಾಡ್ತಾ ಇದ್ದೀರಾ. ವೆರಿ ಗುಡ್ ಟಾಪಿಕ್ ಯು ಸೆಲೆಕ್ಟೆಡ್ ಟುಡೇ, and definitely the good message will leave today. And we have called eminent speakers who are well versed in this subject. Wonderful things you are doing it now.
Because people are talking about third wave, and in Hassan people have become more serious. We don't know what will happen.
Yeah.
Serious about social distancing or but morning in our liquor store there is still crowd, huge crowd in the morning.
Hello, sir, Dr. Santosh.
Yeah, hi, Kottresh.
Sir, hello. I could see your video at some press conference or something. And it is a wonderful topic, and it is approached to the public also, not only doctors, public also.
Yeah.
And I want to have the copy once again. I want to see. Just please send me once again.
Yeah, I'll send it. Yeah, I'll send it.
Kottresh, namaste.
Namaste, sir. As a president of IAP Karnataka, must be enjoying the situation, and you are doing a wonderful job through this digital technology. And hats off to both secretary and as well as you for Karnataka IAP. And this time, both we joined NNF and as well as IAP. Good topics you have been selecting. Wonderful things you are doing it.
Thank you. Thank you, sir. Kumar, can we start?
Kumar sir, I think we'll start.
Yeah. On behalf of IAP Hassan, sir, we are going to start. On behalf of IAP Hassan and Hassan Institute of Medical Science, I welcome all our speakers, Dr. Santosh Sohn sir, Dr. Praveen Kilnani sir, Dr. Dinesh Chirla sir, Dr. Kashi sir, and Dr. Basuraj GV sir, and Dr. Praveen Venkatagiri sir for this seminar. As third wave is very, very important, and everyone are talking about pediatric wave. We thought that a webinar on this is a must, because most of us are from different parts of our country. Speakers are from different parts of the country, and they will be managing very well, so that the silent points can be carried out, and we will be prepared for our COVID wave in children. I would like to call upon our dynamic HSG Dr. Basuraj GV to start this introduction. Basuraj sir.
Thank you, Dr. Kumar. Respected our National President of 2018, Professor Santosh Sohn sir, our Karnataka State President, Dr. Ashok Datta, and Secretary, Dr. Amrish Patil, our NNF President, Dr. Quatresh, Praveen Venkatagiri, and our team Asan, Dr. Kumar, Dr. Sudhir, and all the esteemed faculties like Praveen Kilnani sir, Dinesh Chirlaji, Dr. Praveen Venkatagiri, Professor Santosh Sohn, and all. When Kumar called me a few weeks back, just he wanted to conduct one preparation for a third wave. It was an art of the discussion 15 days back, where the things in all the media, third wave is and most likely the pediatric is going to be affected. In that context, subsequently, the Indian Academy of Pediatrics came with a statement, yes, third wave is going to affect, there is no doubt in it. But what is thing is, it is only affecting the pediatric is not the thing. It is going to affect all the susceptible at that time.
Okay, sir.
So in this context, the best thing is, it is not the argument whether the third wave is going to be there or it is not going to be there. What is most important for a practicing pediatrician, whether you are in a public sector, whether in a private sector, is how do we prepare ourselves for this third wave? In that context, this today's webinar is going to make a lot of going to bring in a lot of messages and how do we prepare for a third wave with an experience like Dr. Praveen Kilnani sir, Professor Santosh Sohn, Dr. Dinesh Chirlaji, Praveen Venkatagiri, Dr. S. Balasubramaniam sir from Chennai. Sir is the one who has got an experience of more than 4 decades. So I'm sure it will send a right message to our pediatric and neonatal community. So IAP and NNF coming together and conducting this webinar. So this is something unique. With these few words, wish you all the best for this unique program, which is organized by IAP Asan team, led by Kumar, Dr. Sudhir Bengaluru, Dr. Prakashappa sir, and all other members of IAP Asan district and Karnataka and NNF, IAP Karnataka and NNF team. Wish you all the best for this.
Thank you, sir. Thank you so much. You've been within a few sentences or few words, you have really set the tone for today's meeting. Thanks to our dynamic secretary that we have a very good galaxy of speakers here today to throw light on the topic. And as you told, IAP Karnataka has already started preparing, forming various committees, as all of us are aware, under the dynamic leadership of our state branch president, Dr. Ashok Datar. And I would call upon Dr. Ashok Datar to give a few brief comments before we proceed. Over to you, Dr. Ashok Datar, sir.
So welcome to SG Kashi sir. Just joined sir. Kashi sir is joined just now.
Welcome, Kashi sir.
Hello.
A very good evening to you all. Dr. G.V. Basaraj sir, Professor Santosh Sohans, Dr. Praveen Gilani, Dr. Dinesh, my friend Dr. Koturesh, and of course our Vice President Dr. Sudhir. I thank all the pediatrician friends in Hassan for arranging this webinar, which has a galaxy of speakers. Now, I, however, wish that the heading should have been or could have been battling COVID instead of sailing through COVID. Anyway, that's a different matter. The burning question under debate today is what more can be done to safeguard the children from COVID. Now, I would suggest that such of those young parents below the age of 45 years who have neither suffered from COVID nor have received the vaccination could be identified and prioritized for vaccination to safeguard their children. Now, this is a suggestion from my end. See, you will be all very happy to know that hectic preparations to meet the third wave head-on are underway by IAP Karnataka, and we should be ready with our module within a couple of weeks. I'm also very happy to inform you that Dr. Deepak Chirodini is on his way to recovery. Gentlemen, attacks on doctors have occurred in the past, and I'm sure they will continue to occur in the future also. The only activity which might mitigate this problem to a certain extent is adequate counseling, especially in informing the possible outcomes, including referral to higher centers and possibility of demise, which needs to be certainly stressed. I thank the organizers for giving me this opportunity to say these few words. Thank you very much.
Thank you, sir. Hats off to your leadership. That IAP Karnataka is going to come out with a module within 2 weeks. I'm sure all of us will feel more empowered 2 weeks hence to tackle this wave, and probably we would be sailing through rather than battling COVID, as you said, after you give us the module. And I would now like to call upon our NNFK president, Dr. Koturesha from Shivamogga, to offer a few comments. And we are hearing neonates also suffering MISC like picture. We have got reports today in the newspapers from Bangalore and other places. So NNFK is co-hosting this meeting. So I call on the president of NNFK to offer a few comments. Over to Dr. Koturesha, sir.
Thank you, sir. You rightly said the pediatric case starts from newborn. Newborn is a part of pediatrics. And definitely Kumar has taken the initiation of joining both NNF and as well as the pediatrics. And we learned that galaxy of speakers, Dr. Santosh Sohans, Dr. Balasubramaniam, Dr. Praveen Gilani, and Dr. Basaraj, and Dr. Dinesh Chirla. And I remember Dr. Kashi as a walking vaccine man. So we want to hear more about him regarding the prevention of this corona in this situation. This is a wonderful session because it's a burning issue also. Everybody says it's a first wave, second wave, third wave, attached to the pediatrics. Now we are in the third wave age. And there is a dilemma of how to go with a situation in a newborn, an infant, and a toddler, and adolescent. Because there is a different facts. Unlike adults, we can admit in a ICU places, adult we can play wonderfully. But in a pediatric, when a pediatric baby admitted in NSU or a PSU, somebody should be involved like a mother or somebody who is looking after the baby. We cannot take independently, we cannot leave the baby in a PSU setup. So this situation, Dr. Kumar arranged this galaxy of speakers wonderfully, and thanks for both IAP and NNF members who have been coordinated well and wanted to like hear more from you, sir. Thank you, Anand.
Thank you, sir, for your opening remarks. Am I audible, sir? Am I audible?
Yes, Sudhir, sir. Yes, sir.
Yes. Thank you, Dr. Koturesha, sir, for your opening remarks. Definitely NNFK along with IAP will be preparing together to prepare both for neonates and pediatric age group. Now, Sir? Am I audible, sir?
I can hear, sir.
Yes.
Yeah.
Now we will begin the lecture series for today. The first topic is going to be about the apprehension regarding the third wave of COVID-19. So is it just a media-made hype, or are we really going to get it? And if at all, when we get it, and how we should tackle it, by none other than Dr. Santosh Sons, who was the national president of IAP from Karnataka in 2018. And as a true academician, he always puts his heart and soul into whatever he does to promote IAP's programs. Actually, he has worked in so many committees. Currently, he is the professor and head of the Department of AJ Institute of Medical Sciences and Research, Mangalore. He is Chief of Pediatric Intensive Care and Neonatology. As we are all aware, intensive care and critical care are his areas of interest, and he has a lot of national and international publications to his credit, and he is going to throw more light on the apprehensions that we have about COVID-19 infection in children and neonates. Over to Dr. Santosh Sons, sir.
Okay. Can you hear me?
Yeah. Now we hear.
Yes, we are hearing.
Fine. Yeah. Good evening, and it's a great opportunity to be and see my friends here on the virtual platform. And one thing I would like to mention that we used to have a lot of program. I think if you all remember our dear friend Dinesh, he was there that time. Hassan was one of the most vibrant branches of Karnataka as well as our India. Now, after his sad demise, I think there was a lull. And again, I think Kumar, Sudhir, and all got together and have, I think, made it more vibrant. This time I'm seeing a lot of programs and a lot of activities coming from Hassan. Congratulations, and thank you for inviting me for this. So when this topic about apprehension was given to me, so I was wondering what basically I need to talk. What is this apprehension? Apprehension is that being unsure of what's going to be. So from the time when we started having this pandemic, which sort of ravaged through the world, I think 31st of January was the first case which we reported. And in fact, there may be some of us who must have had all the symptoms of COVID, I think pre-January, and we thought just it was a viral fever and most of us became better. Many of us did have those symptoms, what we thought. Now we are in a stage where we have had first wave and now we have gone into the second wave, and now we are having real apprehension what is going to be. Many of us have lost our friends, many of us have lost our relatives, and definitely we need to be having apprehension about what's going to happen to the children in the next wave. So as I was sort of reading about that, I thought, what would have been the apprehension of the people in the previous pandemics? So this was in the Antonine plague, which came sort of in early for the first millennium, which came and ravaged the Roman Empire. And possible this thing they thought was because of smallpox and measles. But what was the apprehension of that? Interestingly, this time, this age, what happened was there were so many people dying, almost about 5,000 to 10,000 people in that small area dying every day. So people thought that there is nothing we can do about it. So in that time, let us enjoy. So what they started was that they started merrymaking. Then they started having parties every day, and the morality came down. They said, whatever we do, the gods are not there because they are not saving us. So let us enjoy. So the morality came down, the religion came down, and people were just enjoying, and they think the days are not many, so let's enjoy. This was the apprehension they had, that we are not going to live, let's enjoy. Then came the Black Death. This was one of the biggest pandemic we ever had. I think from the Florence, where it started with possibly Yersinia pestis, was the organism which came in the black rats from, of course, like now it must have come from the China, the ship which had gone to China and come back. So this was the thing, almost about, they say 75 million to about 200 million people had died during this pandemic. What happened at that time? See, basically what happens is we all sort of pray for the God, and we sort of say that protect us. That's a time when they realized that the God was not protecting them from this pandemic. People were dying. They were the bodies, the piles of bodies which was put in these temples in the Rome and the Italian and even the other areas in the Europe. So they lost faith. This is the time when happened was that the strength of the religion actually came down. And also what happened was real estate came down, because people were sort of there were not many people, because so many people had died. There were hardly anybody sort of buying the lands. So people sort of came down. And what had happened was the city, the maximum impact of these deaths were there. So what happened was there were overnight rich people, because the relative, somebody had died and all the fortune came to these people. And also that's a time when initially what was there was that there was the city people who were rich and the poor people. This is a time when sort of the power sort of disseminated even to this thing. And of course, as I said, people started looking at the thing, because what they say, as the people thought other than the religion, this is the time when they really thought the stage of a renaissance came in. Because if you see, after this 1354, when this pandemic ended, the European Renaissance came in, because a lot of work on the paintings, the music, and the science came in after this thing. And if you see, this was the cholera epidemic third. Actually, it originated in India. Almost 1 million people died in India because of this cholera, and followed by this great Bengal famine. So there was a big thing which came in. So apprehension those time was even because our poor people would not have any food to eat. And a lot of people lost their life in that. And of course, this was the Spanish flu time. We have sort of a record. Why Spanish flu is Spain was the only country which has not censored. Basically what they used to do, America, England, everywhere, they used to censor that how many people had died, how many people were infected. The Spain was the only country which said like they won't censor. So they knew that number of deaths were coming more. The news was coming from Spain. That's the reason it is called Spanish flu. And also their king also was infected. So that what the apprehension of the people during the Spanish flu. The Spanish flu, when that happened, that people knew that it was spreading to the thing. Because what happened, if I go to somebody's house, can I get it? What will happen to the school, children's school? This is some of the schools actually in Chicago and New York. They said that our schools are much cleaner, much safer than the home. So they used to send to the school. These are the two cities which had this school being the better place than home. So this is the time when they really started, how can we prevent that? Whether there is any drug. There were so many drugs were used. In fact, vaccines, so many bacterial vaccines were used during the Spanish flu, but without anything, because they didn't know it was a virus at that time. So the apprehension that whether it will spread to this thing, what happened? So this is the time when a lot of industrial revolution was taking place, and a lot of what will happen to the industry. All those things, apprehension was there. Now coming back to that, our pandemic, that we are in the third wave. So main thing is the media. Media is the one which is creating the apprehension. Majority of the time, it is that when the way they speak in the media, way they propagate in the media is the one which sort of causes this problem. So this was one of the first paper media thing which came. This is Dr. Ravi. He was a virologist from Bangalore. So he said that this is the time when the third wave will hit kids in a big way. He warned the world. Everybody took, all the media took it with the glee that we don't have enough pediatric COVID care beds, ICUs. This has to be scaled up. This is a fantastic thing that we need to work out of this thing. This was again by our Karnataka TSC task force chief, Sudarshan, which he said, second COVID wave may peak in May, flattened by July. This through their Sutra app, they sort of predicted that by flattened by July, but third wave could come to October. Who are the ones who are vulnerable population? Because adults, the older people, they've got the vaccine, or most of them have had a problem during the first wave. 18 to 45 were infected in the second wave in a large number. So, and also they've got the vaccine. Who are the vulnerable ones? So this is our child from 0 to 18 years are the most vulnerable, who don't have a vaccine, who didn't get infected. That's what the thing. So they predicted that it could be in this age may have number of COVID infection. So children below 18 years at the risk of COVID in the third wave, and they said the first wave less than 1% of the children were infected, but in the second wave they were almost more than 10 to 15% of the children have not been able to get vaccinated, so they're at the highest risk. So also some of the children are getting serious disease in the second wave. They said some of the places like metropolitan cities, they've seen serious cases like Missy, and the ones which are going in for the pediatric intensive care thing. And phase 3 is inevitable, because if you see most of the pandemics, either they have a different phases, waves which come, because if you say wave, there is no word in the medical literature for wave. We say that whenever there is an increase in number of this thing, we call it as a wave. So phase 3 is inevitable given higher level of circulating virus. You must have seen first wave. What happened was we saw somebody in the house is infected, but usually it would stay 1 or 2 people. But this second wave, everybody, you have 5-6 people living at home, all of them getting infected with, because circulating community spread is in a big way. Because of the mutation, it's got a spreadability much more than the first wave. So what the expecting mothers also, what is the apprehension, what are expecting mother? Because there's a large number of, if you see pediatric practice, the number of patients have come down. Only once what we are saying is the physician, radiologist, and the gynecologists, obstetricians were having a lot of cases of them. So what does the expecting mothers feel about that? So this is about COVID worries of Indian pregnant and unprotected mothers to be. This was one of the instances. It came in paper that a person whose wife was about to give delivery, she had COVID, and baby was born normally, but mother had to succumb. She was on the ventilator, and that father was crying. He has to look after 3 orphan children. So this is this type of lot of stories we are seeing. There are others who are already they are infected. This is the girl that is Jagrati. She was married. She was very, very careful, but she heard a story of her friend who got pregnant and both baby and mother dying. So she was so much worried, and it came in the thing. So, but luckily for her, she was okay by the time. So you have seen even in Bangalore, there was a doctor who was sort of a 7th month. She was infected. She was, they sort of aborted the baby. She was on ventilator. She died, and she was crying. That there's a video about she crying just before the thing. This is from Pune. This was about then Maharashtra. They say there was about 0.1 million. That is about 100,000 cases of estimated pediatric infection during the age under the age of 4 during the second wave. So, as per the State Health Department, an age analysis of confirmed COVID-19 shows that there has been a significant rise in number of infection, which is there. So almost at that time, between January to May 29, so almost about 100,000 pediatric cases were there. So However, there is reassuring in the recent Lancet study across 7 countries that estimated fewer than 2 out of every million children died of COVID during that. That means only 2 out of a million COVID died during the pandemic. The collaborating to this fact, another study from Israel that finds that children up to age of 9 have little or do with the spread of the coronavirus. They are not the ones who really spread. The super spreaders are not with children who are less than 18. This is again that study from Lancet that is, it's a mild, which is saying COVID-19 is a milder disease for infant, but we should be ready. We should be careful. We should follow all the protocols. This is what they say. Now, what has happened? The government has got scared because if you see the handling the second wave, there was oxygen shortages, there were bed shortages, though there were a lot of time which was given to them. The vaccine shortage, vaccine problems, all these things. That's why the central government, our Prime Minister, Honorable Prime Minister, had taken the lead and said, third wave, we need to have the infrastructure ready. Same thing is happening in every state. We are sort of gearing it up. And if you see this Bombay municipality, that is BMC, has taken up this. I think they have taken, they were the first one to form a task force. I think our Dr. Suhas Prabhu is heading that thing from Bombay, and they're coming out with a recommendation for this. That is what will happen. What is the apprehension what the public has? What is the apprehension what the politicians have? What is the apprehension what the doctors have? What's the mothers have? This is the apprehension they're trying to sort of solve by giving the recommendation. So be ready, but no evidence that the third wave will come. Some of the doctors are saying, epidemiologists are saying, because this model is by it's not a scientific data we have that definitely this third wave is going to come. It is just a computer analyzed or done analysis, sutra, this thing that we were going to have third wave, and so many pediatric cases are going to be there. But if you see what happened during the first wave, because NNF has a data which they collected, they had about 1,549 cases. Out of that, 71% did not have any problem, and 21 had a problem, but most of it is about premature. And 1.6% was less than this, and about remaining about out of 10% had remaining with between later this thing. So what, with this in mind, the apprehension of the public, apprehension of the politician, apprehension of the society and the association, IAP came together and said, they came out with the sort of protocols, what should be done. So Indian Academy of Pediatrics has said, through the children remain susceptible to COVID-19 infection, it is highly unlikely that third wave is predominantly as exclusively affect the children. It also said there is no evidence to suggest most children with COVID-19 infection will have severe disease in the third phase. This again, Randeep Guleria, you must have seen him most of the time. He is on either NDTV or our India Today, this thing as a thing. He said he's a director of AIMS who said that he quoted from the Indian Academy of Pediatrics saying that highly unlikely third wave will predominantly or exclusively affect the children. And we don't have a scientific data that whatever is infected will be like the adult which will have severe infection. So Indian Academy has sort of come out with few things. I'll just go through as a question answer this thing. That is, what is the possibility of the third wave of COVID-19 in coming months? This is what they said. What they said is there is possibility of the third wave, because what happens is we don't know because the fragile DNA and RNA material, what happens is that it keeps changing. You get mutation. If it can either become more virulent or it can be less virulent. Many of the time what has happened is over the pandemic, the next phase becomes less virulent, what we see in H1N1. So the disease is sort of becomes subtle, and it will be in the community and nothing will happen to whoever gets infected. So one of the apprehension is, are children at greater risk in the third wave as being discussed in the media these days? So IAP what it has said, children are as susceptible as adults and older individuals to develop infection, but not severe disease. It's highly unlikely that third wave will predominantly and exclusively affect the children. Another apprehension what we have, are children likely to suffer from severe disease as being witnessed in the adult population in the current? Thing is, almost about 90% of the children what we have seen is mild or asymptomatic. Therefore, the incidence of disease is not high in children, because first wave, so many of them what we saw, even in the second wave, mostly it has been a mild one. Because even in Karnataka, I saw some days back a data which we got about 575 pediatric cases on that day out of some 35,000 cases. Out of that, only about 70 required high dependency and 6 required ICU care. So you can imagine where the adult one, it is much more, so many times more what we say. So it is mostly asymptomatic. We may not have, or from what data we have from that thing. So are you ruling out the possibility of severe disease in children or this thing? Because this is what everybody wants to have, whether the parents, whether the mothers, whether it's politicians, whether the society, everybody are asking us, I want to rule out. Nothing will happen to the child. So dictum here is better be ready. We don't know really what happens, because how the second wave took us off our feet, we don't know. So best is to prepare for the worst and hope for the best and pray that next phase the virus will be less virulent. So severe disease occurs in children, but there's no evidence indicating that, no proper data that this will have a severe infection. So we have heard about severe disease due to COVID-19 is already occurring in children. What do you have to say about it? So key message is, yes, definitely, because if you see the percentage what adults get, almost 10% of them land up in moderate or severe one. But we don't have that thing. Occasionally we get that disease and need higher care like PICU, both during acute illness and after 2 to 6 weeks due to immune condition MISI caused by COVID-19. But majority are likely to recover. Even what we are expecting, most of the places like Bombay, Delhi, maybe Kerala, all had little early, almost a month before us in Karnataka. So whatever MISI we are going to see is going to be in another 2 to 3 weeks. And some of the places like Dr. Basuraj was telling that they're getting at least 3 cases of MISI during this time. So many of them just will be febrile induced syndrome. Some of them may have Kawasaki. Some of them may have multi-organ. See, we need to worry more about the multi-organ, because other two we are managing, and most of that what we have seen is they become better with just the treatment, either immunoglobulin or steroids. So what would be the preparation in case of the third wave comes and affects the thing? This is the thing. Apprehension is that, are we prepared? Are we able to prepare? Because if you see 136 billion people.
Sir, sorry to be interrupting.
Yeah.
Would you please conclude? So
yeah,
we have a narrow speaker. So
okay, fine. So take home message is, children are as susceptible as adults. Almost about 90% of the infections are mild or asymptomatic. Therefore, the incidence of severe disease is not high in children. Children occasionally get severe disease, may need ICU care, but during both acute as well as 2 to 6 weeks later because of the MISC, we need to be prepared for more inpatient beds, intensive care beds for children, and the management protocol. Thank you so much.
Thank you, sir. That was an excellent presentation based on both facts, stories, and also the scientific explanations and possibility of what could happen and why we should be prepared and what we should be prepared for. Sir, thank you very much, sir. We will be taking questions after another 2 speakers deliver their lectures. And we would move ahead to Dr. S. Balasubramaniam, who is a very well-known name in the lecture circuits of pediatrics. He is an infectious diseases specialist, currently working as medical director and head of Department of Pediatrics and IAP and in Kanchi Kamakoti Child's Trust Hospital from Nungambakam, Chennai. We from Hassan IAP very, very fondly remember your visit to Hassan, sir, when you came here for infectious diseases CME and also for the National Satellite Conference, where all of us members had the opportunity to interact with you personally. So I'm sure I personally have learned a lot every time that I listen to you during conferences or webinars. I'm sure he's not going to disappoint us this time also. Over to Dr. S. Balasubramaniam to deliver his talk on their current experience in children at Kanchi Kamakoti Hospital, Chennai. Over to you, sir.
Thank you, Dr. Sudhir. Please allow me to share the screen.
Yes, sir.
Yeah. Just a second. Okay. Thank you, Dr. Sudhir. At the outset, I am thankful to Hassan IAP and Karnataka IAP for this opportunity. I am actually emotional because of my close connection. All of you know we miss someone from Hassan. I have visited Hassan so many times, and my eyes get filled with tears when I think of my dear friend. So with an emotional beginning, I thought I will deliver this session concentrating on personal experience with reference to the data related to COVID-19 in our hospital during the last 13 to 14 months, particularly with reference to the clinical data and the numerous publications we have had in the last 1 year. There are learning points from our experience which I thought I will share with the audience. In the end, of course, there are some necessary take-home messages for practicing pediatricians like me, which I thought I will convey to the audience. From March 2020 onwards, all of us started worrying about this COVID-19, and the government, of course, insisted on us to start a separate SARI ward, and it's called Severe Acute Respiratory Infection Ward. And over the last 13 to 14 months, this is the data on 3/5/2021. We have hospitalized 2,000 and odd children, and we have treated 250 cases which had proven COVID-19 infection with PCR. Fortunately, we encountered only 2 deaths expectedly. And surprisingly, both the deaths were actually unrelated to COVID-19. COVID-19 was probably a bystander in those cases. One was a child with acute myeloid leukemia, tumor lysis syndrome, terminally ill, came and died, was incidentally COVID positive. Second was a child who had vasculitis. We couldn't identify the cause of vasculitis. Biopsy, of course, showed features of leukocytoplastic vasculitis. Child developed acute renal failure and died. Was also PCR positive, but never had pneumonia and things like that. And we had handled 120 cases of MIS-C so far in the last 1 year. Surprisingly and fortunately, our recovery rate has been 100%. All of them are doing very well. Coming to the distribution of cases of COVID-19, there's something very interesting we saw. One was that there is a bimodal incidence of COVID-19. We saw maximum number of cases between 1 to 5 years, and another peak was seen about 10 years. This is our data in the last 1 year. In fact, the second wave, we have seen more number of older children getting hospitalized than younger children. So most cases which had occurred below 1 to 5 years was there in the first wave. And with regard to the MIS-C, this, of course, the figure shows 106. The remaining 14, we don't have full data. That's why I'm not including them. The age distribution, again, is surprising, quite contrary to international data. What we have seen maximum number of cases have occurred between 1 to 5 years, because most of the international publications and other centers, they have reported most cases above 10 years. The next age group, which is common, was 5 to 10 years. And the least was, of course, 0 to 1. And we did see some cases about 10 years. This was a surprising finding of having missed a lot between 1 to 5 years of age. Incidentally, the number of cases of Kawasaki we had handled had come down actually. We had seen around 49 cases in the last 14 months. Out of these 49, most of them had occurred between 1 to 5 years, very few about 10 years. And this is almost 50% less than the usual number of cases. We see around 75 to 100 cases of Kawasaki in a year. Last year it had been less. Probably it has been replaced by MIS-C. Another interesting thing, all of us know, everybody talks about risk factors for severe disease in adults and in children. If you look at literature, the data suggests that infants below 1 year, those who are obese, those who are diabetic, those who have asthma or chronic lung disease or sickle cell disease or immunosuppressive condition, or chronic disease like genetic, neurological, metabolic or congenital heart disease, they are known to be high risk for severe disease in COVID-19. To our surprise, what we did, we analyzed our data. We wanted to look at the mortality and morbidity amongst high-risk groups. And this is, of course, under review in a journal. What we found, surprisingly, you look at this immunocompromised group, majority of the immunocompromised group had only mild disease. Whereas in the healthy infant group, it was more than the immunocompromised group. Severe disease as well as moderate. Severe disease was more, moderate disease was less. And in the immunocompromised children, in spite of being on chemotherapy, they did very well. Severe COVID was nearly 0%. This is quite a surprising finding. That more literature is emerging from the West also. Many immunocompromised children, in contrast to adults, may do very well with COVID-19. However, they should be admitted and they should be monitored. The other data we analyzed recently has been the use of remdesivir. Out of the 250 cases we had handled, we used remdesivir only in 9 out of 250. And what did we use this drug for? Severe pneumonia, moderate COVID in a child with quadriparesis, pneumonia, rheumatic heart disease with COVID, severe COVID and MIS-C, both COVID PCR positive child, severe pneumonia with ARDS. So we hardly use remdesivir outside severe pneumonia, and the prognosis had been good. This is one observation we have made. Looking at our own publications, this is what we did in March 2020. What did we do? We compiled an article with the help of a pediatric rheumatologist at UK and with the help of one of the pediatricians from Karnataka, Dr. Neha, and we put a title, What We Know and So Far and What We Do Not Know. That was early COVID. We knew very little. And we published it in April. To our surprise, this has had 120 citations in less than 1 year, probably due to the curiosity rather than the scientific content. But in that article, we suggested a primitive model of treating and looking for COVID. Look at what we suggested. We divided the classification into suspect and non-suspect, history of travel, everything, sick, not sick, treat as LRI, basic principles. We never knew anything about remdesivir. We never knew about the use of steroid. That is what we wrote. We could not predict. But there is something we wrote which I am afraid is true. We fear the great impact, indirect impact of COVID-19 on children. How? Many sick children are not being brought to the hospital at the right time because they all think they will get COVID if they go to a hospital, but they will go to a supermarket, they will go to a market, vegetable market with less precautions. And we also predicted that there's going to be a drastic economic impact. So the economic impact has been more on pediatricians' incomes and pediatric hospitals as much as on anything else. And then the first case of COVID PCR positive child, what we saw surprisingly, had all features of MIS-C. And this child we had great difficulty in managing. The reasons were many. What was it? This child had a Kawasaki-like illness with bulbar conjunctivitis. This child had a maculopapular erythematous rash. This child had cheilitis and glossitis. And he also had pedal edema. And in addition, he also had pneumonia. And he was also PCR positive. We don't know whether this was Kawasaki with COVID-19. We took the help from experts online. And then what we did, we gave IVIG. We gave steroids. He didn't respond. Then we didn't know what to do. We just hit him hard with tocilizumab. And look at the graph. The moment we used tocilizumab, everything came down. The fever came down. IVIG did not work. Steroid did not work. All the inflammatory markers came down. This is history. This is the first case from India and in Asia. Then we sat down and prepared a review article. We thought we should sensitize Indian pediatricians to the concept of the so-called PIMS-TS. The PIMS-TS name came from UK and Europe because they identified first. Now it has become MIS-C thanks to WHO and CDC. You know, whenever the Englishman says something, the US people will always say something against. That is what has happened. So we decided to write a review of this case, of this disorder. And look at what we recommended. We recommended IVIG as first line. We said aspirin to be considered at different dosages. And we suggested methylprednisolone 10 milligram per kg for 3 days. And we said, if these things don't work, you can try biologics like tocilizumab, infliximab, or anakinra. This is what we wrote. In fact, even today, it holds good 1 year after the introduction of MIS-C to the community. Next is our teammates observed unusual neurological manifestations in COVID-19. 3 cases. What did they have? One child presented with acute febrile encephalopathy and status epilepticus. He had all qualifying features of MIS-C. We gave IVIG and steroids. He recovered. Another child, simple febrile seizures. It turned out to be MIS-C. He also recovered. Third child, febrile status, COVID PCR positive, recovered with levetiracetam. What did we conclude? COVID-19 can present with any system manifestation, dermatological, neurological, renal, cardiac, respiratory, vascular, etc. The next thing, there was a raging controversy in pediatrics. All adult physicians and pulmonologists, in addition to doing CRP, D-dimer, etc., they started doing IL-6. And we tried to do it as a research project. And we did plasma biomarker profiling thanks to our collaboration with the National Institute of Research in Tuberculosis, where there is a NIH research unit. And what did we find? We found that PIMS-TS or MIS-C children had very high levels of IL-6, IL-15, all the chemokines. And this was compared with controls, and definitely it was more. So we concluded that the plasma biomarker profile of PIMS-TS or MIS-C is very different from COVID-19, very different from normal children, very different from children who are seropositive. Of course, if you ask me, is it a useful test? I would say, please leave it to the researchers. You look at the graph here. In moderate and severe cases, and in those cases in PICU, IL-6 was very high, but so was CRP. So we don't do IL-6 for diagnosis or for monitoring. We have done it only for research. And we need more information from scientists about the levels at which you should worry about IL-6. Until then, we should not be doing. The other things we found out was that those children who got into ICU, their age was higher. They had more mucocutaneous manifestations and GI manifestations. They had coronary findings more often in the echo. They required more fluid boluses. With regard to CRP, we hardly have seen CRP of less than 100 in these MIS-C cases. So the average CRP was 176 or 77 milligrams in those who went into ICU. And outside ICU, it was 137, very high CRP. Today, if you find a CRP of 200 to 300, you should always think of MIS-C. Then, what we decided, we have seen enough number of cases. Let us sensitize the Indian pediatricians to this. We collected data from our initial only 19 or 18 cases, and then we published in Indian Pediatrics. This is a very interesting picture which demonstrates what we saw. In contrast to the severe COVID-19, we saw a lot of GI symptoms. Quite a few children referred as appendicitis. GI symptoms are very common. Respiratory symptom, not cough, but tachypnea and respiratory distress is very common. Features were present in more than 2/3. Fever was there in all of them. 1/3 had lymphadenopathy. Cardiovascular symptoms like hypotension, fatigue, palpitation, tachycardia was seen in 2/3. CNS symptoms like fatigue, seizures, lethargy, coma was seen in 1/3. And of course, 2/3 of our children went into the ICU. All of them recovered. We concluded with our analysis that PIMS TS or MIS-C can present with any sign or any symptom. What we found, one of the reasons why our prognosis had been good is because there was lower incidence of coronary artery abnormalities. Only 3 out of 19 we have seen abnormalities. In the 120 cases, I would say only around 15 had coronary abnormalities, or probably less, but many of them had myocardial dysfunction. And in this study last year, we found very little PCR positivity, and majority of them had antibodies even in the last year. Zero mortality was observed. Then what we did we collected samples from all children from March 2020 onwards. And we analyzed the antibodies amongst these children. We compared them with 3 groups. One group was normal children who came for surgery or for some outpatient checkup. One group was children who had MIS-C. One group was those who had COVID positivity, COVID PCR positivity. And another group, children getting hospitalized for non-COVID illness. So we analyzed this in 463 children. And this is what we found. Look at this graph. From the first week, when we started doing from April to December, or November, the seropositivity gradually climbed from 6% to 21%. Overall seropositivity in our series was 21%, much higher to the extent of 40% in children with MIS-C. This is what we published. All of us know from the time COVID pandemic came, the pediatrics department and pediatric hospital has been suffering. So we analyzed the pattern of admissions in our hospital. We found total admissions came down by 1/3. We saw less of ARI and AGE, less of wheezing, and PICU admissions came down by half, and this is what we reported. This is a disturbing trend which is continuing, unfortunately. The next study we didn't stop with only antibodies and the profile of children who got admitted. We analyzed microbial translocation factors. It was a very complicated project. We did it with the help of NIRT, and we found higher levels of CRP, alpha-2 macroglobulin, serum amyloid protein, LPS, CD14, LPS binding protein, and haptoglobulin, name anything. All these microbial translocation factors and features of systemic inflammation were higher in MIS-C. And look at this. We observed MIS-C in a higher age group. This more in males. Serology positivity was 100% in the later group. This is a later study. And underlying conditions are hardly there. We did observe coexisting infections in 11%. 1 out of 10 with MIS-C had some infection, significant or insignificant. And we also found that the CRP level was high in those children with MIS-C, with lymphopenia, neutropenia, and hyponatremia being more commonly observed in MIS-C. Having shared with you our research data, what have we learned? That is what I must pass on to the audience. We have learned that very few children with COVID-19 will need hospitalization, as pointed out by Dr. Santosh Stones eloquently in the previous lecture. Let us not worry too much about COVID-19 third wave. Very few children will require hospitalization. And most of these children will recover with only paracetamol and supportive measures, at the most zinc and IV fluids. Even if there are high risk factors, very few will die. Syndromic management of acutely ill children during the COVID-19 MIS-C pandemic is essential and enough in most. Mind you, COVID-19 is a great mimicker of serious bacterial infections and other viral illnesses. We should not forget our breadwinners and our garden variety infection, all because we expect a third wave. Steroids in acute COVID, yes, in severe cases, not in mild and moderate cases. We have no reason to justify giving steroids to mild and moderate cases of COVID-19 or to those without MIS-C. Secondary infections throughout the world and also in our experience have been extremely rare. We have data, we are collecting data on it. And sick children, and when in doubt, we should always have a lower threshold for antibiotics. In fact, I can tell you that in all the cases of MIS-C, initially our policy is to take a blood culture and start ceftriaxone. And if the duration is more than 4 or 5 days, we also add doxycycline, reassess with culture and scrub typhus ELISA report. As I said earlier, remdesivir is rarely indicated. I think WHO has removed it from the essential list, and we have used it only for 9 out of 250, and most of these cases were in the last year rather than this year. Mind you, MIS-C is a clinical diagnosis. It's like JIA. It's like Kawasaki. It's a diagnosis of exclusion. People ask me, sir, how do you confirm MIS-C? There is no single diagnostic test. It's putting together all the pieces in a puzzle. If you suspect MIS-C, a good echo is essential. It may not fit into the criteria, but the echo shows coronary artery dilatation or myocardial dysfunction. You are going to treat it as MIS-C. IVIG, unfortunately, costly, is the first line of therapy for MIS-C as of today. Low dose versus high dose steroid, the debate is on. I vote for high dose steroids. On personal experience, we use high dose steroids. Finally, at the end of it, the most important duty of a pediatrician is not to miss a MIS-C. We can't afford to miss a MIS-C. And unfortunately, you look at the definitions of MIS-C available, RC, PCH, WHO, CDC, you can use anything. Most of us use WHO. Since we started very early, we are still using we are collecting data from all the 3 definitions. But by and large, we use the RC, PCH definition. But you look at the definition, if your child has 3 days of unrelenting fever, inflammation markers are high, and seropositivity there, then you can label it as MIS-C. But that is dangerous. We should not miss an infection and diagnose MIS-C wrongly. That is my last take-home message. Thank you very much. And thank you very much, Hassan and Karnataka IAP, for the opportunity. If you have any feedback, negative as well as positive, please mail to sbsp@gmail.com. Over to the organizers. Thank you very much.
Thank you, sir. As lucid and clear as ever, with very clear take-home messages. The audience will offer comments or questions at the end of the next talk. And for the information of all the faculty, we have another link where the audience have logged in. We have around 250 delegates who are listening to your lectures, sir. we will move on to the, we will Am I audible, sir? Am
Yes,
I
sir,
audible?
you're audible. Yes.
Yeah. We will move on to the next lecture. Dr. Praveen Khilnani will be speaking on what to expect next in COVID in pediatrics. Dr. Kumar will introduce Dr. Khilnani. Over to Dr. Kumar.
Dr. Khilnani, sir, we welcome you from Hassan IAP and Karnataka IAP. Most of us know about him. He is an director and senior pediatric consultant, as well as in the critical care department from Madhukar Rainbow Children's Hospital, Delhi. And whenever we hear his name, he is for pediatric intensive care. And over to you, sir. Praveen Khilnani, sir, he has a lot of affiliations. He is with American board also. So over to you, sir.
Good evening. Good evening, all. And thank you for inviting me to this seminar with many graceful and many knowledgeable speakers, which preceded me and are going to follow. Am I audible?
Yes, sir, you are audible.
Okay. All right. So the topic is corona disease and what's next. So what I thought, since there is already a description about the coronavirus, the pandemic, and people who are worried about it and all that. So I just concentrate a little bit on, the post-COVID situation, which we are witnessing currently in Delhi, where we are seeing lots of cases of MISC. So last year, if you look at the outbreak, lots of cases were there. And then May 12th, 2021, the number of cases, of COVID have been highest in the world, and there's a lot of mortality. And this was a question as to why are we seeing younger patients getting involved much more, maybe because of mutant corona, or maybe many of us put our guards down and we just thought, sort of got a good feeling that we have gotten over this. Now we know that viral RNA enters the cells, causes cytokine storm by TNF, interleukins, lymphopenia, lung endothelium causes leak, NARDS. And recently, because more children and young adults are getting affected, and somehow the interesting thing that I noticed among the community was that they are getting lots of CT scans on their own. So I think that is something we should discourage, that it's not the CT scan. Most patients can be treated at home. And this is a message that should go to the public unless if there is a saturation dropping or respiratory distress. So we know that the incubation period is 0 to 14 days, may present with cough, sore throat. And I'll just quickly go through this, where we will get to how in pediatrics we should be suspicious of COVID. Myalgia, runny nose, diarrhea, abdominal pain, nausea, headache was also seen in, though less often, in adults. And if you look at the chest x-rays, generally tend to show some patchy sort of patches where the CT scan scoring also has been done. And how do you prevent it? Social distancing, mask, disinfection, hand hygiene, home quarantine, all those things, PPE, I will not concentrate on. So what the request was that when you get to the ICU, in a very small percentage of children with COVID, or these are the patients who are now presenting 2 to 4 weeks later after recovering from COVID illness as MIS-C, we always try oxygen and high flow devices before intubation and try prone. If this is one thing that most pediatricians, even the non-intensivists, have learned, that oxygen prone positioning before getting into an intubation. And what does prone positioning do? It tends to selectively ventilate the ventral part. So if you're supine, as you look at it, it's so much of opaque down here, and then you prone it, you get a better ventilation. So really, no specific treatment, supportive care, including ICU care and close clinical monitoring, oxygen, HFNC, high flow nasal cannula or non-invasive ventilation, and invasive ventilation only in a select few, because ARDS management remains the same, supportive. And as you all must have heard, some very, very sick older adults and older children have required even extracorporeal membrane oxygenation, ECMO. Steroids, if high fever for more than 5 days, medical therapy with remdesivir is FDA approved, but as Dr. Balasubramanian pointed out, it's not really the first thing that you go on. First thing is just go with the supportive treatment. So anakinra, low molecular weight, heparin, all of these are COVID management. So what I'm going to now talk mainly about multi-system inflammatory syndrome, and especially in South, where you have just sort of come to a tapering part of COVID. And in 2 to 4 weeks, trust me, you are also going to see these cases much more. And many of the people in Chennai have already begun to see. In Karnataka, Dr. Basavaraja just told me they're seeing 3 cases a day, and it's different kind of severity. So really, if you look at it, I think for all practical purposes, WHO definition works out just fine. Fever more than 3 days, and any 2 of the following, like rash, hypotension, or shock, or features of myocardial dysfunction, evidence of coagulopathy, acute GI problems, and then inflammatory markers like elevated ESR, CRP, or procalcitonin, and then no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcus. And this is a point that should be made, that you could be missing a severe infection if you just label somebody as MISC and just start IVIG and steroids without any antibiotics. And then there should be an evidence of COVID-19 serology positive or likely contact. So management is supportive. I think admission to the hospital is required, in a better monitoring situation. But many of the patients that we are seeing in our pediatric ICU currently have left ventricular dysfunction or having respiratory distress. Because with these, it becomes very, very difficult to treat them in the ward. So supportive treatment, of course, with antibiotics, IVIG, if there is shock, 2 grams per kg per day. If no shock, 2 milligram per kg per day. Methylprednisone, if shock, 10 to 30 milligram per kg per day. If no shock, 1 to 2 milligram. So here, there is somewhat of a controversy depending on the symptoms. And if no response, then repeat IVIG or give tocilizumab 4 to 8 milligrams per kg every 12 hours. So what I'm going to talk about is just the rationale behind all of these therapies based on the published evidence, so that we are clear in our own mind what kind of mechanism are we looking at. IVIG, American College of Rheumatology guidance recommendation, 1,000 to 2,000 milligram per kg, or steroids as first-line treatment. An assessment of cardiac function and fluid status in MISI, with shock is recommended before IVIG. And administer IVIG once cardiac function is restored. So what is the mechanism of action? IVIG has a generalized anti-inflammatory effects. Immunoglobulins are antibodies synthesized by B lymphocytes. IVIG is derived from the pooled human plasma of thousands of donors. And most preparations consist of intact IgG with trace amounts of IgA, IgM, soluble CD4, CD8, HLA, and cytokines. So essentially what we are achieving with IVIG is opsonization and neutralization of many toxins and microbes, as well as complement activation. And so let's say many of these patients are going on aspirin because of the anti-inflammatory COX-2 inhibitory mechanism. But let's look at the steroids, which are the sort of key point in terms of anti-inflammatory. The anti-inflammatory action of corticosteroids are thought to involve phospholipase A2 inhibitory proteins, collectively called lipocortins. Lipocortins in turn control the biosynthesis of potent mediators of inflammation, such as prostaglandins and leukotrienes, by inhibiting the release of precursor molecule arachidonic acid. And corticosteroids currently are being used both in active COVID illness, ARDS, as well as in MIS-C. So what about interleukin-1 antagonist, like anakinra? The IL-1 antagonists prevent the binding of IL-1, a pro-inflammatory cytokine that mediates various inflammatory and immunological responses, to interleukin-1 receptors. So similarly, the native IL-1 receptor antagonist by competitively inhibiting the binding both IL-1 alpha and IL-1 beta to the IL-1 type 1 receptors. And the dose, everyone goes with this recommendation, 2 to 10 milligram per kg per day, subcutaneously, or IV divided every 6 to 12 hours has been recommended, with a 3-week at-home taker. So now, just few words about the interleukin-6 antagonist. And the prototype of that is tocilizumab. Mechanism: IL-6 receptor inhibiting monoclonal antibodies block IL-6 mediated signaling by competitive binding to both soluble and membrane-bound IL-6 receptors. So if you look at all of these issues where things have not worked out by giving IVIG or have given steroids, and you have persistent elevation of inflammatory markers, as well as the fever, and patient is sick, then I think tocilizumab should be used. What's the dose? Tocilizumab may be considered for patients with continued fever 24 hours after IVIG or steroids, and moderate to severe presentation. And mark my word, I'm talking about moderate to severe, not every patient. So a single dose of tocilizumab, 12 milligram per kg in patients less than 30 kg, and 8 milligram per kg IV, maximum 800 milligrams in patients 30 kg or more is recommended. Now, there have been some issues about availability of tocilizumab, availability of remdesivir, and all of these. That, of course, you know, in India, we end up getting lots of those. So in summary, what I wanted to emphasize was that COVID-19 is a worldwide pandemic. Prevention is possible, and many of the countries have done so. And we must not leave the guard down, as the third wave may even be dangerous, although there is no evidence that it has to come and it has to involve the pediatrics. But I think it is better to be prepared, continue social distancing, PPE mask, disinfection, hand hygiene, home quarantine. And most of the patients can be treated at home. Let's get the facts. 90% of children who have gotten COVID illness have been treated at home, including their families. So it's a very, very small percentage that gets very sick, and even a smaller percentage out of all of these people end up needing the ICU and have a high mortality. Now, currently, we had all the Delhi hospitals, the pediatric ICUs, we sort of pooled our data. In the past 2 weeks, MIS-C on an average seen is about 20 cases in each hospital. And we unfortunately lost one case with very, very severe LV dysfunction, but otherwise most cases have survived. And that's a similar data that we are having from North. And I'd be very interested in seeing in this second wave, Dr. Balasubramaniam, KKCT Hospital, other hospitals in Chennai as to what are their outcomes, and we can talk about that during the discussion. So one of the issues that has come up is, well, in children, we are not vaccinating right now. So are we going to see a higher severity in children? Well, the research trials is going on. We are hoping that within 2-3 months, for the smaller, like less than 18, the vaccine will also be available. But, India is a populated country. To get everyone vaccinated is a major challenge. So currently, most hospitals, even private or government, are doing vaccinations. And we're trying to do our best and have made sure that the oxygen stock, the beds, the bed strength, and having more ICU beds, I think this is the best we can prepare. We do need to remember that at the end of the day, it has a high mortality in extremes of age. So we must be prepared. And survivors who have survived from COVID or MISC continue to guide us. Thank you very much for a patient listening.
Thank you, Dr. Praveen Khilnani, sir, for sharing your experience so very vividly in Delhi. And Dr. Kumar has questions. And I also thank Dr. Praveen Khilnani, sir, and Dr. S. Balasubramaniam, sir, for completing their lectures well within the allotted time. And Dr. Kumar has got a few questions for the first 3 speakers who would be taking them as a panel. Over to Dr. Kumar. Dr. Kumar?
Hello, are you hearing me, sir?
Yes.
Yeah, now you are audible.
Yes.
Please go ahead with the questions. The first three speakers will take it as a panel.
Okay, first question is from Dr. Narayanappa, sir, from Mysore. Dear Khilnani, sir, good evening. For moderate COVID with hypoxia, which oxygen delivery do you prefer between CPAP and HFNC?
I think the best is to start the NRM, non-rebreathing mask. And then if you have to advance it further, it's better to have the availability. CPAP is much, much easily available, but it's better to have availability of HFNC, high flow nasal cannula. And most of the patients, we have been able to prevent any further progression or even intubation and ventilation. So if you currently see many of these companies who make HFNC are really getting their equipment everywhere.
And he also says that, sir, as there is more of oxygen waste with HFNC. Is it true, sir?
Yes, it is true. However, if your flows don't have to be 3 ml per kg, you can be 2 ml per kg. It's adequately humidified, and one needs to be in that kind of isolated place. Yes, CPAP may give you some conservation of oxygenation, but HFNC, the blender, which blends the air with the oxygen, you don't have to do 100% oxygen. You can do 30%, 40% oxygen and blend it with the air so that you don't waste a lot of oxygen.
There is another question is, when do you initiate NIV mode of ventilation?
See, indications for initiation of NIV mode are clinical. Usually, whenever you have oxygenation failure, and what do we mean by oxygenation failure? If somebody is breathing room air and the saturations are less than 92 or 90, 89, that's oxygenation failure, and that's an indication for admission. So now let's say you have started the oxygen by nasal cannula or oxygen by mask or a non-rebreathing mask. And on that, the flows are increasing to whatever is physiologically feasible. And if your saturations are less than 89, 88, and you are having carbon dioxide retractions, which means how do you tell that the patient who has very high CO2 will be lethargic, will be tachypneic and getting tired out. So that's a clinical decision. But if you really want to be objective, you can do a blood gas, venous blood gas, and you can decide on initiating the NIV. But most of us have been doing these decisions on a clinical, very close assessment of respiratory rate, retractions, breath sounds, oxygen saturations, and maybe get a VBG.
Thank you, sir. Thank you, Narayana Prasad. The second question is, some parents get blood parameters done by first or second week of testing COVID positive by themselves. Significance of very high D-dimer value alone with other parameters, CRP being in normal limits in an otherwise asymptomatic child. Any follow-up is required? Dr. Deepthi from Bangalore has asked this question, sir.
Any of the speakers?
Any of the speakers, yes, sir.
Yeah. Dr. Bala.
Can I answer this question?
Yes, sir, please.
Yeah, please.
This is a true problem, real problem. Basic principle is when you ask for a test, you must be prepared for the action that you are going to take when you get test positivity, negativity, low titer, high titer. Any treating physician, pediatrician should ask these questions. How this test is going to change my management. So when you are asking for D-dimer, you must know the purpose for which you ask. Asking for D-dimer for a mildly symptomatic, for a moderate COVID, today in an individual who doesn't have high risk factors for thrombosis, it is not rational, it should not be done. Okay, that is the first thing. The second thing, you must understand the basic physiology of D-dimer. D-dimer indicates that there is a vasculopathy going on. D-dimer elevation is not specific for COVID-19. In fact, we have also learned second-line investigations are suggested, and we have also seen cases where culture-proven enteric fever, D-dimers, you have seen 10 times the normal. Culture-proven. Admitted as MIS-C, D-dimer done elsewhere, culture-growing salmonella typhi, we have not reacted to it. In fact, dengue, again, referred as MIS-C, referred as COVID, D-dimer done, sky high, 5,000, etc. Child completely normal, dengue PCR positive, COVID PCR negative, we have not reacted to it. So the fundamental point is that D-dimer can go up in any vasculopathy. The level should not be treated. The clinical status of the child should be treated. When I say clinical status, what is it that we are looking for? We are looking at the risk of thrombosis. In our own institution, I can tell you from our statistics, 250 cases of COVID, 120 cases of MIS-C. We have not had a single thrombosis. In a recent review article, as well as in a article published in Archives, the incidence is very low. So, to use D-dimer for starting prophylaxis with enoxaparin in children is not sound. We know very little about this D-dimer. Currently, they say in a high-risk child, if the D-dimers are more than 5 times the normal value, high risk for thrombosis, not high risk severe COVID, high risk for COVID, high risk for thrombosis, obesity, child with a family history of thrombosis, child who has a cardiac disease, known to have predisposing factors for thrombosis like SLE. Those children, D-dimer more than 5 times the normal, then for starting prophylaxis with enoxaparin. So the numbers don't matter. We should not be wasting money on D-dimer and IL-6.
I, in
Thank
fact,
you, sir.
had gotten one pediatrician who called who said that this child recovered from COVID illness, and it's been 2 weeks now, and I just got D-dimer, ferritin, and CRP. All of them were elevated, but the child is completely asymptomatic. So I did advise to him that don't keep following the tests. Do follow the child clinically. If he were to get into MISC, he'll start showing some symptoms, some fever. So I'm not saying that you ignore these tests, but don't just do the test. It's important to, examine the child and follow the child, clinically.
Thank you very much, sir. And the next question is how to identify problematic PIMS bar miscellaneous at periphery like talukas, etc., where 2D echo, D-dimer, troponin, etc. are not available. This is a question from Dr. Rajaram from Shivamogga, sir. Any of these speakers, please.
Zoom meeting. Webinar.
Can I take this question or
No, that's okay.
Well, you can.
Dr. Sohns, you want to?
Yeah. Basically, MIS-C is as I said, it's a clinical diagnosis.
Light beautiful.
Could we please request
Dr. Kumar, please mute all the audience. Dr. Kumar, please mute all the audience.
I will.
Dr. Misbah. Yeah, thank you.
Okay, MIS-C is a clinical diagnosis, and it's a diagnosis of exclusion, as I put in this summary. If you can't get an echo done, if you can't get a D-dimer, don't worry. The criteria are very clear. You have a child who's got more than 3 days of fever. Entire family has had COVID in the last 3 weeks. Child did not have any symptoms. Child comes to you, looks like a child who's not having the straightforward dengue, straightforward UTI, straightforward typhoid, straightforward typhus, but has something to suggest that this could be vasculitis. What does it mean? Child has severe abdominal pain, not appendicitis. Child has vomiting. Child is extremely tired, out of proportion to the fever. Child has got red eyes, no discharge. Child has got some lymphadenopathy. Child has got some rash. Even if the CRP is not very highly elevated, I would start thinking of MIS-C. That's one. So clinical diagnosis is very, very important. But I put it in my presentation, echo is necessary. Why? When you have a doubt, I always joke, the children don't read the WHO guidelines, RCP guidelines, Nelson, and they don't read WhatsApp, young children, and present to you with straightforward MIS-C. They present with all sorts of manifestations. So it can be variable in an individual child. You have to be aware of the possibility. It is ideal to do an echo when you doubt. In fact, I wouldn't wait for an echo, not IVAG or MPS, in a child who has all features of MIS-C and who has shock. And I'm confident of my diagnosis. In the same case, as I said earlier, I wouldn't withhold antibiotics until I get a diagnosis. I will start. So the message is, even if you can't get an echo done, if you have a clinical diagnosis, which is likely to be reasonably right, and if you are sure you are not dealing with you are not having any definite alternative diagnosis, it is MIS-C unless proven otherwise. It is very difficult for a general pediatrician, in fact, for me also, to strike a balance between not missing a MIS-C and not making an overdiagnosis of MIS-C. So we have to be extremely careful. That's what happens. Extremely careful, and it is shrewd clinical judgment. Assess, reassess, reevaluate, and whatever investigations are appropriate, please do it at the appropriate time, and then proceed. Don't worry if you can't get an immediate echo done.
And I would like to add up one thing.
Echo can be normal and the child will be in shock. That can also happen.
Yes. So I think it's important for the clinician to realize that when you have left ventricular dysfunction, and if there is a poor cardiac output, there are clinical symptoms where you may have tachycardia, you may have enlarged liver. Yes, it will not detect a coronary aneurysm, but the poor LV function, like any patient with myocarditis or cardiogenic shock, how you diagnose. Don't forget that MISC does not sort of prevent those clinical parameters that you can always use. And I think that's a very, very good point made by Dr. Balasubramaniam, that if you have a patient who has all these symptoms, conjunctivitis, rash, fever, and all these, don't withhold the therapy just because you do not have echocardiogram.
Thank you, sir.
And also simple, there is a simple, IAP has come out with the guidelines for mild, moderate, and severe, including MISI also. I think it's available. I think they can just is there. So I think
it's in April 2021. It's on the website also, so one can download.
Santosh, the IAP has not classified as mild, moderate, severe with regard to MISI.
No, I'm saying COVID cases.
COVID agreed.
Yeah.
COVID agreed.
Yeah.
And they have given one flow diagram of MISC.
Yeah.
Just one. Yeah.
In MISI, there is no classification anywhere of
That's right.
mild.
But what they say about the fever, febrile, FIS and your Kawasaki-like disease and multi-organ failure. With the three categories, some of them have categorized into three.
The febrile inflammatory state is a term which is coming and going. It came, now it's gone. It's only MISI. And maybe we will get probably a classification of MISI which is mild and severe. Currently, MISI is MISI only. There are no adjectives added to that. As of today, it may change. I'm not sure.
Thank you, sir. We'll move on to the next question. Does high inflammatory markers like high CRP without respiratory involvement, which shows normal saturation, need steroids like in adults? This is a question by Dr. Srinivas from Bangalore. Anyone can take this.
Only having isolated CRP, which is high, I don't think that's an indication for steroid. But if you have a combination along with fever, rash, and presentation like MISC, I think that's an indication. So when in doubt, you can always do it, but that causes overuse of steroids. So I think there's a word of caution also that needs to be there, that just one number does not determine that you do that, because hyperglycemia and getting cases of mucormycosis and those, lot of people in critical care community are blaming very, very low threshold for use of steroids and indiscriminate high dose steroid. So what I would say is that try to follow the criteria. There are given criteria like D-dimer, CRP, ferritin, the rash, the clinical findings and post-COVID antibodies. There, I think you can make a case of a sick-looking child who would need. But just pure number, elevated CRP doesn't mean that you should go on steroid. Dr. Balasubramaniam, you could please comment.
Yeah, I will share an anecdotal experience which I saw. We had an adolescent boy who was 10 years old, who came with exactly 2-3 days of fever, with vomiting, headache, and he was having drowsiness, neck stiffness, and total count was high. CRP was 256. My PG diagnosis was MISI, but lumbar puncture grew pneumococcus. So beware of high CRP. CRP might indicate, CRP is like a signal. It tells you that something is burning. It doesn't tell you what is the cause for the fire. It is a fire from a house kitchen, or it is a fire in a factory, or fire due to a communal riot. It doesn't tell you. You have to analyze. We should not be treating CRP numbers with steroids. We should be extremely careful. That too in India, high CRP is not synonymous with MIS-C. You have to correlate with other findings. Enteric CRP can go up, UTI CRP can go up, osteomyelitis CRP can go up, any acute bacterial infection CRP can go up sky high. Meningitis notoriously, pneumococcal infection notoriously. So I don't think it is safe to give steroids unless you have a clear-cut diagnosis of MIS-C. You should not be treating those numbers recklessly.
Thank you, sir. Well taken. Now the question is from Dr. Madan Goda Patil from Vijaypur. What are the markers to differentiate Kawasaki from MIS-C?
Yeah, they say the Kawasaki and MIS-C, a few clinical differences are very, very useful. If you put a graph, you will find Kawasaki is more a disease of young infants and children below 5 years of age. MIS-C worldwide is a disease affecting older children. 1. 2, myocardial dysfunction is more common in MIS-C. Coronary artery abnormalities are more common in Kawasaki. The peeling following fever is more often seen in Kawasaki than in MIS-C. Yeah, abdominal symptoms, gastrointestinal symptoms are highly uncommon in Kawasaki, very common in MIS-C. Urological presentations are more common in MIS-C when compared to Kawasaki. Shock is more common in MIS-C than in Kawasaki. When it comes to investigations, lymphopenia, thrombocytopenia, along with lowered albumin and hyponatremia are more often seen in MIS-C when compared to COVID-19. Echocardiographically, myocardial dysfunction is more of a clinching diagnostic feature for MIS-C. Coronary artery abnormalities favor Kawasaki. However, all the differences I mentioned just now, they are not foolproof. And even your COVID antibodies are not foolproof. It's essentially a holistic clinical judgment along with laboratory parameters. I am sure in future, like Kawasaki, MIS-C will be called incomplete MIS-C, complete MIS-C, atypical MIS-C. Already there is a refractory MIS-C. This is evolving. But these are the few differences now clinicians have observed. More data is expected.
Thank you, sir. Very well taken, sir. And next question, sir. What is the role of antibiotics in COVID children? Question by Dr. Harish from Hassan. Are there any role of antibiotics?
Mild COVID, no antibiotic. Moderate COVID, no antibiotic. Severe COVID, no antibiotic. Unless you clinically think that there could be an alternative diagnosis or a superinfection. Both in the presence. The problem with us is, again, you must remember that most children with COVID-19 infection are asymptomatic. So if a child has got pneumonia, ill, COVID PCR positive, I don't have the guts to withhold antibiotics. I would give antibiotics. But I wouldn't give antibiotics to a child who has got, garden variety URA, running nose, cough and cold 2 days. I will treat like any other viral infection. As I put in my slides, syndromic management. Pneumonia, even if it is COVID pneumonia to you, give antibiotic as per protocol. Fever, you give antibiotic as per the protocol. Don't be clouded by the PCR positivity. On the other hand, literature search suggests that bacterial co-infections are extremely uncommon in COVID-19. So we have to be balanced. Again, it is only clinical judgment because CRP is not going to it's not going to differentiate between severe COVID and a bacterial infection. The markers are not going to be helpful. Even your procalcitonin can go up in severe COVID. It doesn't mean there is secondary infection. Essentially, clinical judgment. Routine antibiotics, no. Low threshold for antibiotics in particularly those with MSC. That's my take on this.
Thank you, sir. Sir, the question is to Killani, sir. Isn't leak, which is caused by HFNC, plays a role in increase the spread of COVID to healthcare workers? So this question is from Madhu Chandan from Koratgate.
See, any oxygen therapy, HFNC, even CPAP, all of these can spread by aerosol. But that's why the protective equipment is needed in a COVID area in ICU. So none of the ICUs are exempt from the spread because we also have had publication that it's an airborne spread. So I think it's important to keep that in mind. The answer to the question, can it spread? Yes, it can spread. And one has to take adequate precautions of personal protective equipment and the eye shield and all these things.
Well said.
The next question, sir. In Karnataka, we are afraid of seeing very large number of children in third wave. Now that Delhi witnessed large population affected, did you see such a proportionate surge in pediatric group? And how far is this fear justified? This is a question from Dr. Bhuvaneshwar from Mysore.
In second wave in Delhi, we have seen younger children with COVID. But again, if I were to put all the numbers together as to many got ventilated or not, or was there a clearly high mortality, it wasn't like that. The issue here is much more of some of the mutant strains that are being talked about, that they are affecting children. And that's the worry that we have, that because they are not vaccinated, so are we going to see a third wave, which is going to be severe? I think your guess is as good as mine. As long as we don't leave our guards down, we follow all the precautions, I'm quite sure that we will not have that kind of a severe wave. So it's very, very easy to blame the politicians that you put on lockdown too early or you did not do lockdown and that's why this happened. See, I think ultimately your own introspection of your own behavior in terms of distancing, masking, and all that is going to, give us the results rather than us saying in what happened in Delhi is going to happen in South. Right now, we are seeing, yes, I have to agree, very, very few cases of active COVID, new cases, but we are seeing missy because we have been 3 to 4 weeks post-COVID. So we are seeing that. Is that the phenomenon that is going to be seen in every state? Yes, I would anticipate, but nobody can guarantee. So I think we should not leave our guards down, be on the lookout and, be prepared. Be prepared.
Sir, the same one more question to you, sir. MIS-C with LV dysfunction without coronary artery dilation. Shall we start aspirin?
MIS-C with LV dysfunction is not going to be helped with aspirin. However, if there is, one needs to do a follow-up echo, this is where it's somewhat controversial whether you should go on aspirin or not. But in LV dysfunction per se, aspirin has no role, because that's where you need a myocardial support, you need inotropes, you need to treat the, congestive heart failure that happens with LV dysfunction. And these are a small subgroup of patients who will come in the ICU and where you don't really have to go on aspirin to treat the LV dysfunction.
Thank you, sir. One more. MIS-C, shall we manage with steroids alone, sir? And shall we wait for IVIG? This is from Madhuram Krishna from Hyderabad.
Well, the protocol talks about IVIG and steroids. So, this is where once you have diagnosed the condition, that's the recommendation. Yes, it's an expensive drug. If you just don't have anything available, then start methylprednisolone. But I think IVIG would be my choice as the first choice. Dr. Bala,
Can I add one comment here, please?
Yes.
Yes, sir. Please.
As per the latest guidelines from the American College of Rheumatology, the recommendation states that all children with a diagnosis of MIS-C should receive aspirin 3 milligram per kg up to a maximum dose of 81. Because in India, it's only 75 that's available. 81 milligram is not available. Until their coronaries and the heart are found to be normal at 4 weeks follow-up. That's one. 2. Aspirin should not be given to those who have got active bleeding or who have got a platelet count less than 80,000. These are the 2 recommendations that have been made. But in those children who have the Kawasaki phenotype, who don't fulfill the criteria of MIS-C, who qualify to be diagnosed as Kawasaki, even if the echo is normal, even if the LV dysfunction is not there, aspirin in a dose of 3 milligram per kg, unless there is a contraindication. This is the recommendation published in April 2020.
This question that was asked was for LV dysfunction, do you use aspirin? So I think that's where my answer is. For isolated LV dysfunction, I don't think aspirin should be the one.
Now the question is to 3 speakers, sir. What is your experience with mucormycosis in pediatric COVID-19 cases? All the 3 speakers.
I really don't have any experience with. I have not seen a mucormycosis in pediatric age group.
So far, I have seen one case where there was nasal septal destruction in the sinuses, and the ENT people did the surgery on, and we used amphotericin. Just one case. Out of in past 6 weeks, we've seen 100 cases of COVID and had a separate ward. So one case. So I wouldn't be able to say what is the incidence, but Dr. Bala, you have seen a lot of KKCT.
Actually, we have not seen any. In fact, I don't think in pediatrics we are going to see a wave of mucormycosis. I'll tell you why. See, we have been using this methylprednisolone, prednisolone right and left for nephrotic syndrome. We have never seen cases. We have used it for rheumatoid arthritis. We have used it for SLE. So the pediatric health pattern is different from that of adult. We don't have diabetes. We don't have obesity like in adults. And the number of children who receive steroids, they are very much ADEM, what will be taken We have not been seeing a lot of
ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಗ್ರೂಪಲ್ಲಿ ಮೆಸೇಜ್ ಹಾಕಿದ್ದೇನೆ
Srinivas.
Okay. So I don't think mucormycosis is going to
ಸಿಕ್ಕಾಪಟ್ಟೆ ಡಿಸ್ಟ್ರೆಸ್.
Mr. Srinivas, Dr. Srinivas, will you please mute yourself?
I don't think mucormycosis is going to be a big problem even in the 3rd wave, unlike we pediatricians start giving steroids from day 3 of fever or day 2 of fever, or start giving pulse methylprednisolone to all children with COVID. That's not going to happen. I don't foresee mucormycosis as a huge problem. In fact, I can tell you I have seen only one case of mucormycosis so far in my long career. Not because of that reason, I would say mucormycosis is not going to be a problem. But I don't think it's going to be a problem in pediatrics.
Yeah, it's more in adults, I think.
Sir, actually in Hassan, we have seen one case where the child is positive COVID, but he has not received any steroids. And nothing has been done. He is just positive and he has come with eye swelling. We got a CT scan also, which is suggestive of mucormycosis. We did an MRI also, where there is spreading through sinuses. and we started an amphotericin B, and we referred them to Bangalore.
Yeah, you have to look for other causes, including immunodeficiency. Poor COVID may be a bystander also.
This will be the last question, sir. When parents are positive and children are asymptomatic till 1 week, do we advise RT-PCR for children? This is from Dr. Swapna, Hyderabad.
ఇంకా ఉందండి ఏమన్నా
నాకు సార్
మీకండి లేదు చాలండి ఒకటి పెట్టిన ఇంకొకటి వస్తుంది.
Dr. Jayaprakash, please mute yourself.
సరే.
Dr. Jones, please unmute. Please unmute.
The question is, if the child is positive and
Sir, parents are positive and children are asymptomatic till 1 week, do we advise?
no, if they're not they're asymptomatic, what is the reason for having a RT-PCR done on them? If there's no symptoms at all, if they're isolated and this thing, I don't think there's no need to have RT-PCR in asymptomatic children.
I agree.
Unless they are high risk, they belong to the high risk. There is no need for testing. Routine children, unless they have immunodeficiency on immunosuppressive drugs, chronic disease, in which case you would definitely want to test. But other children, there is no need to test routinely.
Thank you, all the speakers, and it was an amazing experience talking to you all. And we will move ahead with neonatal COVID. So I would like to introduce Dr. Dinesh Chirla, who is the head of the department and director of intensive care services from Rainbow Group of Hospitals. He has done DM in neonatology, followed by fellowship in both neonate as well as PICU from UK and then Australia. He has contributed more. He has more than 40 publications, and he has been in the IAP of Andhra Pradesh. Over to you, Dinesh sir.
Hi, good evening, everyone. And that was a great discussion. Dr. Bala sir, Dr. Praveen, and Dr. Santosh sir, all of you did a great discussion. I think all of us are in the middle of MIC. We had a great experience of MIC from our Rainbow Banjara, close to sort of 125 cases so far. And what it was very nice to see some experienced clinician to see how they're seeing different spectrum. And what we now are seeing, as Dr. Bala mentioned, is some of the refractory cases or cases which are going back and, you give an immunoglobulin, you give steroids, they go home. And then last week I had a child who went back and came with arthritis and recurrent to conjunctivitis. And then you start seeing that and more sort of KD-like spectrum. So I think there's a lot of learning for us to see. And there have been patients presenting with vasculitis, HS purpura-like illnesses, along with COVID. So I think COVID can present with anything. My job today is to talk more about what are the challenges with neonatal COVID. And I'll stick to that. Fortunately, from pediatricians and neonatal perspective, the COVID virus has not struck them hard. And absolutely agree with all my seniors who have very clearly said that none of them have been very sick or hospitalized. Now, I want to share with you our experiences, what happened with the perinatal COVID from our institute, and then see about what we have done in our institute and share some of the cases. And I'll more talk about MISN, the neonatal multisystem inflammatory syndrome, some of the cases which we are seeing, and the different spectrum of that. Though again, they are not as common as what we see in children. And as mentioned by the previous speakers, that we see more in the bigger children, though we also see, we saw different, all the age spectrum, but in the newborns, it is much less. In the first wave, in our institute, we were seeing not so sick pregnant women. So we had 58 in our Banjara, 11 other units of our Hyderabad cluster. So total, we had 69. 6 turned out to be positive. all were low risk. 5 outbound COVID people admitted in our unit. But in the second wave, so far, we had 64 mothers who delivered in our unit at Banjara, and there's 19 our Vikrampur unit. We converted 2 of our centers into exclusive COVID centers. 6 of the units turned out positive. 1 turned out positive or a Vikrampuri branch. 2 of the unit in multisystem inflammatory syndrome in newborns. But what we found in the second wave is very sick mothers requiring respiratory support, HFNC, invasive ventilation, non-invasive ventilation. And 8 of the COVID were outbound. And what we saw, as has been mentioned, a lot of community spread. So newborns was picking up COVID more from the caretaker being positive or mother being positive and then referring. Some of our ex-preterms going home and coming back with COVID. So we had, in the early wave, we have 1 child with MISN, which I'll discuss. One was 34-weeker asymptomatic. Another had a variable presentation where sometimes I feel the COVID was an innocent bystander. Some child with seizures, hypernatremia, CPAP. So there were total 27 neonates between the 2 waves where we had COVID positive children. We had a baby as small as 25 plus 5 weeker and 25 weeker were admitted in our units who's still sort of undergoing treatment. I want to share with you what happened with the COVID pregnant women who got admitted in this wave in our Banjara unit. We had 43 got admitted into the ward and 21 into the ICUs. Among the ICU, 8 we managed conservatively, stabilize them and discharge them. The rest 12 of them delivered. If you look at the pattern, those who delivered, they had a CT scores ranging from 12 to 24. They all needed either HFNC or they required intubation. For those who were managed conservatively, either HFNC or NRM, and the score have been less. Most of them have been 10 to 12. One of them had 15 and we still managed. Most of the babies who managed conservative were less than 31 weeks. Most of the babies who were delivered were more than 32 weeks. And that is what has been the indications from most of the colleges, Royal College of Obstetric Society or American College of Obstetric Society. So as a pediatrician and neonatologist, what are your challenges when you're dealing with a pregnant woman who's COVID? Is right from antenatal counseling, neonatal resuscitation, the guidelines regarding breastfeeding, the NICU admission policies, the visitor guidelines, the KMC guidelines, when we should test it, how do we treat neonatal pneumonia, how do we diagnose MISN, and how do we actually challenge the healthcare? A lot of the evidence which we get from the pregnancies are based from what we have the pregnancy COVID-19 systematic review, the living systematic review, which is of nearly 64,000 pregnant women worldwide, and the priority trial, which is from the pregnancy coronavirus outcome registry trial. Like children and like the other age group, nearly 2/3 of the pregnant women are asymptomatic. But however, they have a higher rate of ICU admission. And unlike the first wave, they are at increased risk of death compared to the women who are not pregnant. What is relevant to us also is that there are a lot of increased incidence of prematurity. Some have reported twice, some have reported 3 times. So range has been anywhere between 17 to 22% from different study group. And what of this prematurity is related to iatrogenic, which is we have to deliver because of worsening respiratory distress in mother. And this is what has been shown in the literature. What is the mode of transmission, which we normally see? The vertical mode of transmission is pretty much very, very rare. Some of them have documented IgM, but very rare. None of them could document much in the amniotic fluid. But most of the transmission happens during the postnatal or intrapartum time. And this is what has been depicted in the cartoon by Satyam. There's no evidence of fetal defect or fetal growth restrictions, which have been demonstrated in many of the studies. The normal way of presentation is early onset, late onset of multisystem inflammatory syndrome, and majority of the babies are asymptomatic. If you look at the mode and indication of delivery, COVID-19 pregnant woman is not an indication of delivery. Delivery should be guided by mother's obstetric assessment and physiological stability. So majority of them have to go by the regular sort of route of delivery, which is vaginal delivery. Antenatal steroids has to be given at a regular dose, and so should be magnesium sulfate if preterm delivery is anticipated. Where should this baby be delivered? If it vaginal delivery, preferably in a separate delivery room, or as operation theatre where negative pressure isolation is what is recommended. The neonatal delivery room, a resuscitation corner, should preferably be, if it is in the same room, it should be at least 2 meters away from where the mother is sort of delivering. Mother should have a mask. So should be the obstetrician who is delivering, along with the visor or the eye gear. And when you look at the neonatal team which is attending, they should also have the protective gear. I'll talk about it. A simulation about how you're going to, this is our resuscitation corner, which is outside the delivery room, and a simulation like that, which will help your staff get trained to know how to manage sort of patients delivered. They need to wear gowns, gloves, N95 masks, and eye protection, because we do not know which of the babies will need respiratory support. So this is sort of one of the gear which sort of they wear. Now, what are the issues which have? So, should we do delayed cord clamping? As a practice, we all know the delayed cord clamping is good for both term and preterm babies. When I looked at the guidelines, which has been reviewed by Cochrane from 19 different countries, there has been a mixed of opinion. 5 of the countries contraindicated. Majority of them were like China, Russia, Iran, which wanted to do, because there was a concern that there was a vertical transmission. But countries like US, UK, Canada, Australia, they were more, and Germany, they were more favoring delaying cord clamping, like the way we normally do for other, because vertical transmission has not been proven. Again, if you look at skin-to-skin contact, there is a mixture of opinion. 7 countries feel that we should not do skin-to-skin contact, and 6 countries feel that we should do a skin-to-skin contact. Rooming in, that whether we should keep the same baby in the same room as in mother. Again, there's a division of opinion. 5 feel we should keep in the same room. 4 feel we should consider, whereas 8 countries feel we should not keep in the same room, because they're concerned about postnatal transmission of COVID from mother to the baby. Now, what does NNF say? Now, from National Neonatology Forum, we are going to come up with a more recent recommendation probably in a couple of weeks. But as of now, the guidelines which has come up from last year does say delayed cord clamping, we stick to the thing about you can practice delayed cord clamping. When it comes to skin-to-skin contact, we suggest that we should go ahead with skin-to-skin contact, provided mother takes all infective control practices like wearing on the mask and doing the hand sanitization. What we are against is not to give birth to the baby, immediate birth, because the risk of hospital-acquired infection and risk of hypothermia in such babies. Is there any specific precautions for the guidelines? The NRP guidelines has to be followed as routine or the 2020 guidelines. We need to take specific precautions while giving ET medications, considering as an aerosol generating procedure. All the clinicians who are attending the delivery, including the nurses, should wear the PPE protocol as per the COVID guidelines. There has been a lot of recommendation about using an HME filter during the expiratory wall or at the time of intubation to avoid sort of exposure to the virus while intubation or while bagging. And this is being practiced in some unit. I do not say this has become a routine recommendation, but majority of the units are practicing that. They do put that, like if you're using a bubble CPAP on the expiratory wall or on the ventilator. So this tends to sort of help in sort of screening the virus. Now, once the baby is born, the baby can be shifted to the NICU, or if there is a prematurity, if there's asphyxia, or there's a respiratory distress, through a transport incubator. Should we initiate breastfeeding? This is one recommendation where universally all the countries have come up, said you should continue the breastfeeding, because none of the studies, except for one paper from the Lancet, which has shown 2 sort of places where they could identify. Again, there were some concerns raised about the way the samples were collected, about documenting the COVID virus in the breast. So there's a very clear saying that it is not transmitted through breast milk and you can continue breastfeeding. And what is recommended is mother should carry on all infective precautions like wearing mask and hand sanitization. So if mother is asymptomatic or has few symptoms, she should be rooming in and should have direct breastfeeding. However, she is sick, has cough, fever or dyspnea, or admitted in ICU, or newborn needs ICU, then she can express her breast milk taking all aseptic precautions, and that's how breastfeeding can be continued. Whenever you're expressing breast milk or diet breastfeeding, all aseptic precautions have to be taken by mother to prevent contamination of milk. So this is a summarization of all the practices. As you said, delayed cord clamping divided, KMC skin-to-skin contact is divided, well baby separation is divided, but breastfeeding anonymously, most of the people would like to continue. From Indian perspective, we would like to support all the above practices. Now, once the baby is born, where does the baby go? Whatever, if you think suspect or proven anonymously, if the baby is less than 34-weeker or the baby is sick, baby goes to the isolation in ICU. If the baby is more than 34-weeker and mother is well, then the baby stays in with mother, rooming in, with mother taking all aseptic infective control precautions of wearing mask, hand sanitization, and child is being at a distance of at least 2 meters from the in the crib. And this is the standard sort of precautions. So we have an isolation in ICU, fortunately, which has sort of separate air handling unit. We have 4 such rooms, and that is where we are keeping all our COVID positive babies or COVID suspect babies before we ship them to our regular ICUs. The next question is, what testing has to be done? We just had some questions. Should we do an RT-PCR? Should we do a CB-NAT and rapid antigen test? RT-PCR, CB and NAT have a sort of a sensitivity of around 70%. Specificity is good. Rapid antigen test has a poor sensitivity of 40 to 50%. Most of the unit do an RT-PCR test. CB-NAT, the only advantage is a rapid turnaround time. You might get a very quick sort of results, especially if you have a very 1 or 2 beds only and you want to quickly decide whether this baby needs to stay here or be shifted to the out of isolation room. That's when you may have to do CB-NAT. And especially in some of the cases, like if you're in a distant place or in a place where the turnaround time is very difficult, that is where a lot of people will use the rapid antigen test. But mind you, if you have a strong suspicion, even if the rapid antigen test is negative, you may still have to do an RT-PCR test for confirmation because RAT has a poor specificity. The next question is, when should I do the test? When you looked at the guidelines, different countries had, the Canadians want to do very early, between 2 hours. The CD says do around 24 to 48 hours. The Royal College of Obstetricians says do at the end of 72 hours. Some of the guidelines, some of the institute would say only the symptomatic. But the new guidelines which are coming up would say do between 24 to 48 hours. If you do it too early, there's a risk of contaminated sample. Earlier, the guidelines showed that you may repeat again between 5 to 14 days. And we in our unit did find some of the newborns who were negative earlier, but turned out positive later. So repeat testing did help in some, but when we reviewed the neonatal registry, majority of the people didn't repeat it. And we looked at the practices of all different countries. A lot of do not do that. So repeat testing is suggested only if the child is symptomatic. However, if you have a newborn who is exposed to anyone who is COVID positive, if you're symptomatic, you have to do it immediately. But if they're asymptomatic, mind you, newborns come under high risk group. You may have to do it at the end of day 5. This is in response to some of the people who had asked whether eventually you should do the testing. And anyone who's symptomatic neonate or the late onset sepsis, comes with the late onset sepsis with history of exposure, you should do a screening for them. Let's take some of the case scenarios. So Mrs. S was referred from district hospital, 32-week gestation age, presented with fevers in 6 days, cough, respiratory distress. Her RT-PCR was positive. Her oxygen saturation room air was 90%. She was breathing at a rate of 30. Blood pressure is normal. CNS is normal. Antecedent is normal. We had different cases. While we have been sort of doing these presentations quite a bit in the last 2-3, and every time I'm trying to discuss different cases so that it becomes interesting for anyone who's following that. So this mother had was on HFNC 16 and 60% FiO2. PF ratio was 100. And we had one first decision, and like what we discussed in pediatrics, should we give steroids? Which steroids to be given? Now, when looked at the guidelines, like in adults, most of from the recovery trial or REMCAP trial, everyone talks about giving dexamethasone 6 milligram once a day for 10 days. Now, what we don't know is what does dexamethasone for 10 days does on neonatal brain. Now, because prednisolone and hydrocortisone do not cross the placenta, the RCOG has come up with the guidelines says if your delivery is not imminent, give prednisolone or hydrocortisone to such mothers. But however, if the delivery is imminent, then shift over to dexamethasone and the antenatal steroid dose of 4 doses, 6 milligram. Remdesivir, again, there's a controversy, does it have a role? But especially if in the early course of diseases, if there is an indication, do not withhold it because of pregnancy, you can go ahead and give. As such, pregnancy is a very highly thrombotic stage, so low molecular weight heparin can be given to mother. So this mother went ahead and delivered by emergency section because of worsening respiratory distress. And she delivered a 32 plus 2 weeker with birth weight 1.2 kg, LSCS cried immediately after birth, started on this sort of CPAP and shifted to the ICU. Baby was admitted in isolation ICU for COVID positive suspect babies. Her chest X-ray was suggested by HMD and requirement increased to 45%. So decided to give intubate and give surfactant. COVID RT-PCR was sent at 24 hours, which is positive. Now the big question comes is, what are the tests to be done for a COVID positive newborn? Should we do all the D-dimers, IL-6 in these babies who are positive? Is something which everyone can ask. For asymptomatic baby, like for a baby like this, whom you think all the symptoms are because of Highland membrane disease, who's otherwise behaving well, probably you don't need to do any of the test. But if they're symptomatic or the severe COVID, suggestive of sort of deterioration because of COVID, then after you rule out sepsis, then we need to consider doing seroperidine, IL-6 and LDH. D-dimer's role in newborn is, as such the D-dimer are elevated in newborn and it confuses because now you have a prematurity and you do not know you want to give low molecular weight heparin. In the early phase of our learning, we did D-dimers in a lot of such babies and used to find them quite high. We did not know what to do with this because the babies otherwise well. We decided not to do anything with these babies and we found that majority of the time the D-dimer settles down. There are certain groups who are actually looking at these babies to see whether these babies have any blood clots or any coronary artery abnormalities in future. We'll have to wait for some evidence to come up. But at this stage, majority of the units don't treat this elevated D-dimers in newborns unless you find obvious sort of thrombosis or clots anywhere when you assess the babies. This child had insured, neurosonogram was normal, child was initiated on feeds. Now I had this, looked at Dr. Bala's sort of presentation about use of remdesivir in children. Now, as such, you know, the remdesivir sort of in children less than 12 years is a conditional, like you do as an emergency use. So in a newborn, when you review the literature, and I leave that to my friend Dr. Praveen, who is going to come and probably touch base on that. But from generally reviewing from all the recommendations, they would say in newborns, probably there's no role of any of the antiviral at this stage in neonatal COVID. And thus there's no role of IVIG in neonatal COVID. The one more common scenario which says in this stage is you're doing a lot of video consultations. So if you get a call for a father who's saying, my 1-month-old child has fever, mother had a COVID, so she's quarantined, I'm taking care of the baby, the child looks well, occasionally cough, but I'm fine, he looks fine, he's feeding, what should I do? Can you suggest me some medications at home? And that's the biggest question. What the child doesn't look too bad when you actually assess them. But trust me, any child less than 3 months with fever, we have to treat them like what we do normally. Get them on, examine them clinically, rule out other causes of fever, screen them for infection. And this child turned out to be sort of having urinary tract infection. So COVID could be an innocent bystander in these cases. Baby G was born to a mother with critical COVID, primary 25 plus 4 weeker. Her COVID CT score was 22, Coride 6. She was on 100% FiO2, PIP 38 on 10 in spite of PUM and no evidence of pulmonary embolism. She qualified for going on to ECMO. Parents, they know ECMO beds, I'm sure. So many of you have gone on to ECMO. They know ECMO beds in the country as to get calls from different parts of the countries asking we can organize an ECMO. And at this phase, it was very tricky whether to deliver her or not, whether delivery is going to actually make her clinical condition worse. or it's actually going to make it better? Because when you are in mid-trimester, we do not know. Because the later part of trimester, there's a good evidence to say that maybe it helps in improving the FRC. But when you're 25-weeker or 26-weeker, you do not know because it doesn't press the diaphragm that much. But however, taking all that into consideration, think that maybe the physiological load on the body will be less. So let us go ahead and deliver. We did the baby section in the ICU and delivered this mother in the ICU because she was not even stable to be shifted over to the outside the operation theater. And this baby was delivered 25-weeker plus 4-weeker, 790 armor, poor respiratory birth. Mother was on a lot of sedations, like she was high-dose fentanyl, she was atracurium. So the child came with poor efforts, had to be intubated. It took a long time to pick up, and we had to go ahead and give delirium surfactant to stabilize the child before we shifted him out of the resuscitation cot. And you need to wait with all the protective gear to sort of whenever you do get a surgery procedure. This child was ventilated for 2 weeks and now on HFNC. 2 doses of surfactant, no IVH, COVID RT-PCR was positive for this child, had a PDA, was treated, thrombohepatic was initially, later got improved, neosonogram was normal, child is now establishing feeds. The criteria for MIC in newborn, I don't think there's a standard definition different from the adults. What has been is that we do not in newborn have fever like criteria of fever may not be as much we find in children as we find, we may not find it in newborn as we find in children. What is probably more common in children is more of hypotension or cardiac involvement, like what we find in the children age group. Yes, symptoms are known. As such, it is very rare, but this is what has been sort of criteria which you said adopt till we come up with the definitive guidelines. The screening test is very similar to what has been told in the children population of a tier 1, where you generally do a general screening, rule out sepsis. But if something is like a high CRP and high CSR, along with absolute lymphocyte being less than 1,000 or thrombocytopenia or hypoalbuminemia, then go to tier 2 infection. What we find is we do find a lot of children with high troponin level and pro-BNP levels because children which we found were mainly those who had a cardiac involvement or those who presented with persistent pulmonary hypertension. We did find children with high ferritin levels in our cases. This is the standard kind of treatment, like what has been described in adults. And this is a mother. This was one of the cases we had. 12-year-old, 12 years of married life. Mother had fever since 3 days before delivery, COVID positive, 27 plus 4-weeker. Spontaneous preterm labor, 970 grams, immediately after birth. The child required delirium surfactant, metabolic acidosis initially. COVID was positive, but was sample collected from endotracheal tube. Over the next 24 hours, investigation was sent, which apparently were normal. Child was extubated onto CPAP. Echocardiography showed a tiny PDA. However, on day 4, we find the child had repeated apnea and needed respiratory support. The child started, once we ruled out sepsis, but we noticed the child started having fevers, sepsis negative, some changes on the X-ray. When we did an echo as part of the evaluation, we found that the child had mitral and tricuspid regurgitation with 55% ejection. And there's evidence of sort of, LV hypertrophy during active inflammation. Look at this. We had raised IL-6 and D-dimer, with ferritin levels which was raised, with pro-BNP which was very high, and troponin levels which is also elevated. Now this was our initial phase of learning, and we did not know how to treat. We said, let's go ahead and give immunoglobulin, because steroids and effect of steroids on the neonatal brain is always a concern for a neonatologist. So let's give immunoglobulin. Child seems to have responded, and we were happy. The repeat RT-PCR continued to be positive. However, on day 15, the child again continued to have tachycardia, fever, and have increasing oxygen requirement. That's when the antibody was positive. The child had again all the markers rising. This time, interleukin was high, D-dimer was high, and this is where we decided, let's go ahead and give dexamethasone. We went ahead and give dexamethasone 0.15 milligram per kg per day. and tapered later. And we found this had actually remarkably improved the child's clinical condition, and all the markers started getting better. And child was discharged at 35 weeks and weight of 1,600 grams. And you could find that the TR had improved at the time of discharge, so did the cardiac before the child went home. The other case, which was again interesting, which I think a lot of my friends and colleagues from the western part of India has been speaking about, similar type of cases. 30-year-old primary, non-consanguineous marriage, spontaneous conception, prolonged rupture of membrane. Mother was asymptomatic, counts were normal. She had fever and rash, and she had COVID negative, RT-PCR. Baby was preterm, 2.8, Meconic chain lacquer, no perinatal issue, room in mother. Suddenly developed fever on day 2 life. Got in, did the usual septic screen, nothing found, but suddenly on day 4 had a pneumoperitoneum. There was evidence of duodenal perforation, and I just wondered, why would a child have a duodenal perforation? How it was fixed up, and child was NPO for 5 days. And then just when we thought the child was getting better, he suddenly acutely deteriorated with severe respiratory distress, needing intubation, high pressure, oxygen was in shock. We did an echo, showed severe pulmonary arterial hypertension, dilated right atrium and right ventricle, RV dysfunction. I said, what is happening to this child? Once perforation, this thing. And day 9 of life slowly started improving. We checked his thiamine level, thinking it was low thiamine. The thiamine levels came slightly low. We thought maybe thiamine is pulmonary hypertension. But what we, X-ray didn't give us much clue. The markers were slightly elevated, the CRP. The platelets were fine. Nothing suggestive of infection. But when you looked at the markers, the D-dimer was high, the IL-6, the troponin was high, the ProA BNP was high, the thiamine was low. The RT-PCR was not detected, but the COVID antibody was detected, and mother's COVID IgG antibodies was also high. And this is what was suggested, that probably duodenal perforation could have been a vascular insult to the intestine. And what we saw is probably the pulmonary hypertension, MICN is this. So this child responded to inotropic support, thiamine, and hydrocortisone, and was discharged.
Sir, can you wrap up, sir? Already time up, sorry.
Yeah. This one minute, not more than that. So this was 34-weeker, 1.4 kg. I think very bad obstetric history. So we'll see a lot of these cases now. We don't know whether they're MISN, there's something else. She had 3 abortions, 1 death of a dilated one death earlier, cardiomegaly and LSCS, intubated cardiomegaly with poor cardiac function. COVID antibody was positive. Inflammatory markers were raised, thrombocytopenia, poor cardiac function. If you look at this, very dilated right atrium. COVID antibodies were positive in this child. We gave steroids, we gave high dose, we gave pulse dose steroids, we gave IV immunoglobulin, but the ejection pattern was just 15 to 20%. Had florid pulmonary hemorrhage, started oscillation, started nitric oxide, gave thiamine, but this child just didn't improve. So I think we will see different types of neonatal presentations in the coming 2 months, and we have to be prepared to deal with all this type of cases. So this is the neonatal registry. I think most of you can see from the Indian pediatrics about from different units from the country who have been presented. Thank you, Team Hassan, for giving this opportunity to share our experience on neonatal COVID. Off to you, Kumar.
Thank you very much, sir. There will be interactive session. You have to be there, sir. And those who have questions, please message the questions. We will have a discussion later. Now, I would like to welcome Dr. Praveen Venkatagiri. He has done his MRCPCH and CCT from UK and FRCPCH. He is the head of the neonatology from OM Group of Hospitals, and he is a head of the department of Chinmay Mission Hospital, and he was a past secretary of NNFK Karnataka 2018 to 2020. We like to welcome you, sir. You can take over, sir. Dr. Praveen, sir.
Kumar, can you hear me?
Yeah, you're audible, sir. Please go ahead.
Okay. Yeah, thanks a lot for the opportunity. Let me just quickly go to the talk. So the role of remdesivir and the corticosteroids in pediatric COVID. So I'm going to look at like two things as asked from me. One is the antiviral action, which is remdesivir, and anti-inflammatory action, which is from the corticosteroids. Of course, the supportive care, which is the most important. That's not what we're discussing tonight. Levels of evidence. We are in an extraordinary circumstances where the disease has come. We are managing the disease before even like having an experience in dealing with it. And we are going with the past experiences or the ongoing experiences and what others are doing. So it is expected that during this time, we may not have high quality of evidence, but we have to start looking at how to achieve that. Just for the sake of younger people, the best evidence would be your meta-analysis of systematic reviews of randomized controlled trials, then systematic reviews of cohort studies, and individual cohort studies, and then systematic review of case control studies, then individual case control studies and case series. And probably that's where we are now in terms of what experience or evidence that we have. And most of the recommendations are from the expert opinions on non-systematic reviews of the results. That's the level of evidence that we are going to be talking about. So the published evidence for pediatric COVID management is based on case series. There were plenty of them, and retrospective cohort studies and pathophysiological considerations, and also derived from data on adult population. And I will be only presenting the expert opinion consensus guidelines as such. So the approach that I'm going to take today is like to discuss what is the evidence considered by the expert panels in terms of use of remdesivir and use of corticosteroid in acute COVID and MIS-C, and how we kind of look at the based on the severity, what is the evidence there. So the experts' opinion that I will be talking about is one is the Infectious Disease Society of America, then multi-center interim guidance on use of antivirals. This was specifically looking at antivirals in children and published in Journal of Pediatric Infectious Disease Society, and they're constantly looking at updating that. Then American College of Rheumatology clinical guidelines, and of course our own Minister of Health guidelines, and also WHO. So let's start with remdesivir. Does remdesivir work? Of course, it is known that in vitro activity against the RNA viruses, including MERS and SARS, is proven. And there's also disease outcomes were better with the reduced viral loads in the infected mice. And also in the other animal studies as well, there are clinical changes also have been seen. But will this translate into our clinical practice? Now, Government of India's recent guidelines says that for severe illness, which is severe pneumonia, ARDS, sepsis, septic shock modes, in these conditions, especially we need to look at a child who is needing ICU admission, not because a little bit of tachypnea is there or a little oxygen requirement is there. These sick children, there is a recommendation for remdesivir. Also, they're stating that there is no trial data in children. And it's used to be restricted to severe cases presenting within 72 hours of onset of symptoms. Here again, many questions and doubts will come. Whether starting of remdesivir will stop the progression to severe. No, it's not like that. A child who presents with severe illness and we caught the child within the 3 days, then you could consider using remdesivir. Not a child who comes in with minimal respiratory distress. Now, what is the multi-center interim guidance? Their group who are made of 20 in fact ID specialists and pharmacists from North American Institute, who had multiple teleconferences and web surveys, and they have put up the guideline statements. So first question was whether antiviral agents should be routinely given in COVID-19 infection. Mind you, this is how, like even in swine flu as well, initially were used extremely rarely, but it became a routine practice to give even for as an outpatient practice. Hopefully that doesn't happen in pediatric COVID at least, because nearly all the children need supportive care only, and antiviral may be considered as a case-to-case basis. And when we consider giving antiviral, we could look around if any clinical trials are going around and whether we can participate in that so that we can contribute to the science that is developing. And appropriate monitoring, and if possible, ID consultation, infectious disease consultation would be preferable. And the risk-benefit ratio currently tips towards supportive care in most of the cases. Second question is, what criteria would you define in the pediatric population in whom antiviral may be considered? First thing is there has to be a confirmed COVID. Now, again, this is very important because as we see in newborns, the suspected sepsis, or I feel there is sepsis kind of a thing, can come in, and there could be irrational use of antivirals. So that has to be carefully looked out for. So only rare exception could be made where there is a high suspicion of COVID-19 based on whatever the reason that, like, my parents were positive and the child was with them and stuff like that, for whom a significant delay in the COVID test results are anticipated, and also the child is extremely sick. So in these circumstances, maybe you could consider, but otherwise routinely confirmed positivity for the COVID is mandatory. And severity, this group considered severity based on mainly the respiratory criteria, low respiratory tract infection, and what is the respiratory support which is required. So they have divided into mild, moderate, severe, and critical based on no oxygen requirement, some oxygen requirement, non-invasive support to maximum invasive support, and multi-organ dysfunction as well. So for management of mild to moderate COVID-19, what did they conclude? Outpatients and hospitalized patients with mild or moderate COVID-19 should be managed with supportive care only without antiviral agents. So this is important. And remdesivir for severe and critical COVID-19 is suggested for children with severe COVID-19. This is based on a randomized trial in adults, which showed a shorter time to clinical recovery in hospitalized adults, but the mortality did not change. Of course, the benefit is less certain in children, and the assessment for the need should be informed by where are we in the illness. Just because oxygen requirement is there, are we going to consider, or what is the illness trajectory? Is it worsening? What are the parameters we are considering to say that it is worsening? And what are the risk factors in that particular child which might lead to poor clinical outcomes? So when available, again, the consideration is to enroll into clinical trials. And duration of remdesivir therapy, the panel recommends duration of up to 5 days of remdesivir therapy for children with severe COVID-19. For critical COVID-19, the panel suggests a duration between 5 to 10 days, with the durations up to 10 days on a case-to-case basis for children not improving after 5 days of therapy. There are no pediatric trials that will keep on talking about that there is paucity of the data. And several ongoing clinical trials in the US are evaluating the efficacy of remdesivir alone or in combination with various immunomodulatory agents. You could look up regarding these trials in clinicaltrials.gov. I think total around 60 or 70 trials are going on, including adults, not in pediatrics alone. Pediatrics, very few. Role of remdesivir in the management of MIS-C. Now, MIS-C is considered as a post-infectious, so there's no active viral replication is going on, so it doesn't make sense to consider remdesivir in cases of MIS-C. However, there will be cases where we're not sure whether it's active viral infection or COVID sepsis is going on or MIS-C is there, especially when the child is very sick, where the symptoms are overlapping. In these circumstances, if one is not sure and the child is sick, then probably they could consider remdesivir, but not routinely at all. So the second major question was whether underlying medical conditions do we consider before changing the criteria for the remdesivir. There are no, again, definitive data to support any specific risk factor. Majority of the data is descriptive, and in the reported literature of the case series, so around 25 to 80% of them had comorbidity. Regarding medical complexity, if a child have complex medical disorders, though there is no evidence, but it's generally, it is thought that in these children, you might have a severe disease. So while making a decision about antiviral treatment, you should consider them as a higher risk. Younger age group, there is no evidence to support to make it as a higher risk. And older age, in the sense here, what they fail is that the adolescent age group in the reported cases are more affected compared to a little younger age group. So they could be considered as a little higher risk. Severe immunocompromise is most likely to be a higher risk, and that has to be considered during the decision about antiviral treatment, but not the mild and moderate immunocompromised children. And of course, severe underlying cardiac disease, if it is there, then they are likely to have a severe disease. And similarly, pulmonary disease as well, when underlying pulmonary disease could be considered as considered during making the decision about antiviral treatment. Obesity, it's a challenge though, but number of children with obesity very high, and to what extent we could consider as obesity as a higher risk. Diabetes, again, there is no sufficient data. Who are severe immunocompromised? I'll skip this. Pulmonary disease, there are specific indications that have been given that is available in the guidelines that I mentioned. The second one is Infectious Disease Society of America guideline. This is for both adults and children. Mostly adults is what they have mentioned. Hospitalized patients with oxygen saturation more than 94% without supplemental oxygen. 3 randomized controls have compared treatment with between 5 days and 10 days. And they have failed to show any reduction in the mortality when compared to no remdesivir. Though interestingly, a 5-day course of remdesivir in one of the studies showed a slight increase in the clinical improvement, but a 10-day course of remdesivir showed that there is no clinical improvement at all. Hence, the recommendation is that in patients with oxygen saturation above 94 on room air, there is no need to use remdesivir. In hospitalized patients, less than 94% saturation on room air, including the patients on supplemental oxygen and mechanical ventilation ECMO. These are the severe cases. Again, 3 randomized controls comparing the treatment with the remdesivir with no treatment. The outcomes assessed were mortality, time to clinical improvement, need for mechanical ventilation, serious adverse events. The analysis failed to show a benefit in the mortality at 28 days. And patients receiving the treatment with the remdesivir tend towards greater clinical improvement at 28 days compared to the patients not receiving remdesivir. In addition, there was shorter median time to recovery and also decreased need for mechanical ventilation. This is depicted here. And clearly we can see that the mortality is not, say, significantly reduced, but time to recovery was better. So in these cases, the recommendation is in hospitalized patients with severe COVID-19, remdesivir is better than no antiviral treatment. And also they recommend that the treatment should be for 5 days rather than 10 days of remdesivir in this population. And there is an ongoing remdesivir trial in pediatric population using 5 milligram per kilo on day 1, followed by 2.5 milligram per kilo daily in patients over 14 days. And I think they are recruiting from 0 to 18 years of age. The next medication, corticosteroid. So Government of India guideline, again for the severe illness, the steroids are recommended. Dexamethasone 0.15 milligram per kilo per dose, twice a day for between 5 to 14 days, the duration depending on the clinical response, or equivalent dose of methylprednisolone or prednisone could be considered as well. In case of MIS-C, when a patient fills in the criteria of MIS-C and there are signs of cardiac involvement, like cardiac dysfunction, shock, coronary involvement, modes, or life-threatening conditions, if they are present, then you could use both methylprednisolone and IVIG, and do not forget the antimicrobials as well. And when this cardiac involvement is not there, the first line of treatment, IVIG is preferable, but if you do not have access, you could start with methylprednisolone. Both can be given in case there are other, it's a sick child or they become unresponsive. Infectious Disease Society guidelines for critically ill patients. Among the hospitalized critically ill patients, the odds of mortality at 28 days was 34% less amongst the patients treated with glucocorticoids compared to ones who did not receive glucocorticoids. That's significant. In addition, at 28 days, patients receiving dexamethasone were more likely to be discharged from the hospital, as again shown in this table. You could see the odds ratio of 0.66, and the hospital discharge was also better in the patients who have received glucocorticoids, corticosteroids.
Sorry to be interrupting you, Dr. Praveen. Could you please speed up, because we have another talk on vaccines getting late. Yeah, you will please speed up.
Yeah, sure. So the recommendation is to give the dexamethasone rather than no dexamethasone in these critically ill patients. And in severe but non-critical, it was only 17% lower, but still significantly difference is there. Hence, again, the recommendation is to give steroid in severe but non-critical COVID patients. And in non-severe group, in fact, there could be worsening. So the recommendation is to withhold, do not give corticosteroids in non-severe COVID patients. And similarly, the American College of Rheumatology guidelines as well looked at the role of steroids, as earlier speakers, all of them have mentioned as well. In MIS-C, there is definite role of glucocorticosteroids as a primary therapy or adjuvant therapy based on the availability of immunoglobulin. And in case of a shock or end organ dysfunction is there, you could do both. And that's the same thing depicted in this diagram. And in the presence of hyperinflation, inflammation in children with the COVID, glucocorticoids should be the first line of treatment. And the same, this is interesting, the WHO guidelines says that there's no role of remdesivir. We'll have to wait and see whether that will, change especially for the severity. Corticosteroids, it's the same as other guidelines, that in critical, severe and critical cases, there is a role for corticosteroids, and in non-severe cases, there is no role for corticosteroids. So there's no high quality evidence for remdesivir in children is not available, and some trials are still going on. And remdesivir is likely to be useful in children with severe or critical COVID infection in the early stages. We're not sure about the complications and the interaction with other medications concurrently used. And there is no role of remdesivir as you would expect in MIS-C. And the systemic corticosteroids reduce the inflammation in severe COVID, and steroids have significant role in confirmed cases of MIS-C. Thank you.
Thank you, Dr. Praveen, sir. Now over to Dr. Sudhir.
Yeah, thank you, Dr. Praveen, sir, for going through a plethora of evidence for and against remdesivir and for steroids. We'll take the questions after the next talk. Now, I would be inviting Dr. Kashi, who is well known to everybody. Our president of Karnataka, I described him as the vaccine man. So he's been a member of the IAP Committee on Immunization and also has been the convener. So he's going to really, all of us are really very interested to learn from him as to when we are going to get the vaccine for children and how effective they are going to be. And of course, probably I'll just request him to add on the necessity and mode of vaccination of pregnant and lactating women. Over to Dr. Kashi, sir.
Thank you. I'll just share my screen now. Right. Okay, at the outset. Can you hear me?
Yes, sir. Yes, sir.
You are audible.
At the outset, my sincere thanks to IAP Hassan branch, specifically Dr. Sudhir, IAP Karnataka, NNF Karnataka, for giving me the honor of presenting some data on pediatric COVID vaccines. I confess this is a rather futuristic topic. We don't have any vaccines for COVID in children. But however, I will present some data which may help us decide whether children need to be vaccinated, and if they need to be vaccinated, whether they have to be prioritized or they just got to wait till their turn comes in the line for COVID vaccines. I'll be presenting some data on studies that are going on in children. And well, as Dr. Sudhir requested, something about pregnancy and lactation, COVID vaccines in pregnancy and lactations. The first question we need to ask ourselves is, do children really need the COVID vaccines? And to answer this, we have to ask 5 questions. Is COVID-19 common in children? Is COVID-19 dangerous in children? What is the role of children in transmission of COVID? Because if they are important and if you immunize them, you can break the chain of transmission. Are the COVID-19 vaccines safe in children? Are they efficacious? The last 2 points, we don't have any data. So I will discuss the first 3 points. Now, is COVID-19 common in children? Yes, all children of all ages are susceptible to SARS-CoV-2 infection, and some of them are also susceptible for severe disease. We do not know the true incidence because most of the asymptomatics are not tested. In the latest release from the CDC as of 1st May, those between 0 and 18 years constitute about 12.2%. Of these, 0 to 4 years was 2.1%, and 5 to 17 years was 10.1%. If you look at the data that has been published in the lay press from the Government of India, between the first wave and the second wave, the proportion of children affected almost remains the same, except for those less than 10 years where it shows less. Of course, there's nothing to check the veracity of this data, but it's the general impression that we have been seeing a lot more COVID, but probably COVID in children has not increased proportionately. It's just that COVID has increased, so more children are getting affected. The next question, is COVID dangerous in children? We must remember 12 to 19% are asymptomatic. When they are symptomatic, the illness is milder. The incidence of critical illness, hospitalization, ICU admissions, and mechanical ventilation is much lower than what is seen in adults. In the US CDCA, they have worked out the rates of hospitalization in those between 0 and 4 years at 18.4 per 100,000. and with 5 and 17 years as 10.6 per 100,000, which is almost 1/10 of the figures seen in adult. 1/3 of these may require intensive care. Death is extremely rare in the pediatric age group. In the pediatric age group, the incidence of critical illness is highest in those less than 1 year, and a meta-analysis has shown approximately 17% of all COVID in children are less than 1 year of age. Well, MIS-C, which is being spoken so, and which we heard Dr. SBS speaking so eloquently, we are seeing it more and more often, and that becomes a very important factor to consider when deciding whether children need the vaccine or not. In a systematic review of childhood corona COVID-19, over about 5,829 patients, pediatric patients, if you notice, in those below 1 year, critical illness was found in 14%, which was much less in those overall between 0 and 18 years, indicating that the illness could be more severe in those less than 1 year of age. The next is, are children the drivers of transmission of COVID-19? See, we must remember that for influenza, children are the major drivers of transmission. Hence, it makes sense to immunize the entire childhood population. In fact, Japan almost reduced the incidence of adult influenza, deaths and pneumonia due to influenza by vaccinating only their children. Studies have shown that in family outbreaks, children are rarely the index case. Following school reopenings, outbreaks in schools have been rarely reported, and when they have been reported, the transmission is usually from the staff to the student and not vice versa. Of course, outbreaks of COVID-19 have been reported in residential schools and school camps, but these may be more due to leniency in using the non-pharmacological interventions. So, we have seen that, yes, COVID is common in children, but COVID is not dangerous in children, and COVID does not, basically children are not drivers of the transmission. So why should we vaccinate children? Why is everyone so eager to vaccinate children? We must remember that children less than 15 years account for 26% of the global population. And when we are talking of the goal of herd immunity, we can never achieve that goal unless we immunize this population. We are seeing the emergence of variants which are much more transmissible. We are also seeing rising vaccination rates in adults in quite a few countries. This implies that over a period of time, children and adolescents might be contributing more to the spread rather than the middle-aged and the elderly. And unless children are vaccinated, the return to normalcy will never occur. Schooling will not take off. Lack of schooling, lack of interaction with peers, lack of physical activities are causing a tremendous negative impact on the psychological health of children. And these are the reasons why we should strongly consider vaccinating children. Now, what is the difference between COVID vaccine trials in children and in adults? First, consent is by the legal guardians. And those subjects who are still not 18 but old enough to understand what is going on should give their assent. Both are necessary. Generally, the older recipients will enter the trial first. Dosing studies will be done in them. A dose will be decided depending upon the immunogenicity and the reactogenicity. Following that, the phase 2-3 studies will be done where thousands will receive the vaccines. A few thousands, not 30, 40,000 like the adult studies. Because COVID is reducing in many countries, efficacy studies may not be possible. So it's going to be immunobridging with certain segments of the population in the adult studies. We have also to see that the COVID vaccines do not interfere with the other childhood vaccines. And of course, it's paramount to consider the effect of vaccines on MIS-C, whether vaccines can trigger MIS-C or vaccines will reduce the incidence of MIS-C. We must remember that safety is paramount in clinical trials involving children. We know what has happened to the Oxford vaccine after the report of vaccine-induced thrombotic thrombocytopenia. And very recently, they have described 7 cases of acute myocarditis in adolescents following the Pfizer vaccine. Most of them have come from Israel. There are a few isolated reports from others. Fortunately, they are mild. They present very early, within 5 to 7 days of receiving the vaccine. There has been no mortality, but some of them have required drugs like IVIG and methylprednisolone. So with this background, Pfizer was the first company to test its vaccine in 12 to 15-year-old children. They tested it in a cohort of about 2,260. There were 18 cases in the placebo group versus none in the vaccinated group, giving a vaccine efficacy of 100%. Antibody titers in the 12 to 15 years were much higher than those in the older age group. Side effects were similar. And on 10th May 2021, the US FDA authorized the Pfizer vaccine for emergency use in adolescents between 12 and 15 years. Worthwhile recollecting that Pfizer vaccine, the phase 3 studies in adults were done from the age of 16 years. So Pfizer is the only vaccine which is now recommended for use in children between 12 and 15 years. Pfizer has now planned what is known as a continuous phase 1, 2, 3 studies in children from 6 months to 11 years in 3 cohorts, 5 to 11 years, 2 to 5 years, and 6 months to 2 years, to evaluate the safety, tolerability, and immunogenicity. Close to 4,500 children in USA and Europe. Immunobridging will be done. They will compare the immunogenicity in this group versus the predetermined immunogenicity observed in the 16 to 25-year population and decide whether the vaccine is going to work. Moderna is conducting 2 studies. One is called as the teen cohort study between 12 and 17 years and a kid cohort study between 6 months and 12 years. Again, recruitment has already started. They're going to use a standard dose of 1,100 micrograms in 2 doses. And here it will be an immunobridging where they will decide the number of participants who have reached the acceptable threshold, which will be predetermined for the serum antibody level at day 57 after the first dose. It's expected that this study will complete by June 30th, 2022. The kid cove is the kid component, that is 6 months to 11 years, where initially you're going to have the dosing studies. They're going to decide on what is the best dose. And in part 2, that predetermined dose is going to be given in 2 doses. Comparative is a placebo. They're going to look at the reactogenicity and the immunobridging study. This study is also looking at the adverse effect of special interest and the incidence of MISC. And the estimated primary completion date is sometime in 2023, 2 years from now. We know that Covaxin also has started its pediatric trials. The DCG has approved the phase 2 studies in the age group of 2 to 18 years. Here also, it's been subdivided into 3 groups, 2 to 6 years, 6 to 12 years, and 12 to 18 years. About 525 subjects, 175 in each group. I mean, just compare the very small cohort compared to the studies of Pfizer and Moderna. It's done at 5 sites. The trial has already begun at AIIMS Patna, and we have to see what is the outcome of these trials. Covishield began a small study in a cohort of 300 in children between 6 and 17 years. 240 whom have received the Covishield vaccine, and the remaining 60 received a meningococcal conjugate vaccine. However, ever since the reported association of the vaccine-induced thrombocytopenic purpura with Covishield, this study has been put on hold till further studies have been done to establish the association. And we don't know whether this study will continue or no. The same has occurred with the Janssen vaccine. Their pediatric study also has been put on hold. Now, friends, this was a study published in BMJ sometime early last year, where they looked at the global, regional, and national estimates of target population size for COVID-19 vaccination. This was a study aimed at helping countries to decide what is the number of vaccine doses they will require for each cohort. And if you look at this, school-age children and young people and young children are right at the bottom of the cohort. So this is where the prioritization of children is and is a reality. If you look at the situation in our own country, as of 3rd June, just 2 days back, only 12.8% have received one dose and only 3.2% are fully vaccinated. We still have got a very large cohort of population who are at risk for complications of COVID, hospitalization, ICU care, mechanical ventilation, even death. And till those children are vaccinated, our children are going to be quite low down on the priority list. I know I have been asked to speak something on pregnancy-related vaccination and breastfeeding. I have not got the slides ready, but just a few comments. Now, regarding breastfeeding, I think both the Government of India and recently the IAP, ACVIP has also come out with a position paper. We must remember, but though the vaccines in use in our country today are inactivated vaccines, there is no inactivated vaccine that is contraindicated in pregnancy. In fact, yellow fever vaccine is the only vaccine that is contraindicated in pregnancy. We know that women who are breastfeeding and who have been given the vaccines, antibodies are found in the breast milk, which may be protective. No adverse effects have been noted in the infants of breastfeeding mothers who have received the vaccines. There is quite sufficient data to show that COVID vaccination is safe in lactating women and hence the new recommendations. Whereas pregnancy is a little different ballgame. Although the incidence of COVID is not higher in pregnancy, but those pregnant women who develop COVID tend to have more need for ICU care, mechanical ventilation as compared to pregnant women who do not develop COVID. There are a lot of frontline workers and healthcare workers who are pregnant. In fact, the US has established what is known as a V-Safe, where every woman who has taken the mRNA vaccines and who has gotten pregnant has entered that particular registry. They have close to around 97,000 pregnant women, and there has been no adverse effects noted, either in the women or in the newborns till 3 months of age. And recently there has been a publication about the safety of the Moderna mRNA vaccine in pregnant women. Enough data to show that it is safe in pregnancy. In spite of this data, everyone is a little concerned and a little hesitant in recommending this vaccine in pregnancy without any preconditions. In most of the countries, the vaccine is recommended in pregnancy for those who are at high risk and only after a detailed discussion of the risks and benefits are undertaken. So this is where things stand as far as vaccination in pregnancy and breastfeeding of women. So thank you very much. I'll now stop sharing and will be happy to answer any questions.
Thank you, sir, for your clear presentation. And Dr. Kumar, do we have questions for the last three speakers?
There are only two questions, sir. It is to Dr. Dinesh, sir. Sir, now there are children born to COVID positive mothers. How many? We require a lot of the ambu bags. How to sterilize those things, sir? Ambu bags, then ventilators, disposables. The ventilator circuits are okay. We can use and throw it off. But how to? We have to reuse on another child also. So how to go about it, sir?
We can do the ETCO sterilization, gas sterilization. That is one thing which is recommended, which you can do for which you really can't. Otherwise, you do get disposable ambu bags also. But if you cannot afford the disposable ambu bags, the recommended method for this thing is to send for gas sterilization. So what we do in some of the units is they send it for gas sterilization.
And sir, now, for example, if the child is born to a preterm baby where we have given a surfactant and baby is still not improving, is this now it is already COVID positive baby? Now, is there a role there we have for remdesivir?
See, I think remdesivir as such, the role of remdesivir in adult and children is questionable, as Praveen has presented the data quite nicely. Unless you find that you have a definitive evidence that the current situation for the child not improving is because of COVID, either in forms of your raised sort of inflammatory markers, evidence of an abnormalities on the X-rays, or evidence of sort of any clinical condition which is not explained by sepsis. That is the only place, and you are pushed to the wall. You have nothing to lose. That is where, on compassionate ground, remdesivir has been used in some of the newborns, and including one of the case report on preterm, which has been reported in JAMA, and this and pediatrics sort of we have reported, and they did find that there was an improvement after using remdesivir in those cases. So mind you, but there has been no clear guidelines when to use remdesivir in a neonatal settings. So I would be very, very reluctant to give a specific recommendation that you given 2 doses of surfactant and the child has not improved, go ahead and give remdesivir in a COVID positive. I would say if you found that there's an obvious evidence of sort of COVID pneumonia-like picture on the X-ray, the child is clinically not improving, oxygen requirement is going up, you have a high CRP, you are into early phase of illness, we do have some requiring high ventilator setting, that may be the where you are pushed to the wall, and you need to have a clear discussion with the parents that really remdesivir in neonatal setting is not licensed, but in this case we are losing, and that's probably the reason why we may have to consider in this type of settings.
Thank you, sir. The next question is to Kashi, sir. So, do flu vaccine have any protective role against COVID?
Well, I think the flu vaccine manufacturers are making the best business nowadays. After there were some news reports about the Maharashtra task force recommending a flu vaccine during this COVID time. We must remember that there is no direct relationship between flu vaccination and COVID. One reason why flu vaccine is being recommended is that both flu and COVID-19 have similar presentations. The incidence of flu is going to reduce in those who take the vaccine. So it is possible that the number of encounters to the healthcare facilities will be reduced by flu vaccination, and thus reduce the burden on the healthcare facilities, testing, etc. That is the major reason why the task force gave this particular reasoning. Now, going back, there was an observational study from Brazil which looked at over 90,000 COVID-19 cases. And they found that in that particular study, there was a statistically significant reduction in the severity, death in those who received COVID influenza vaccines versus those who did not receive influenza vaccine. Remember, this was an observational study, not a randomized control study. So conclusions cannot be drawn for that. But it has been postulated that again, the influence of flu vaccine on COVID-19 is more because of this heightened trained innate immunity, a concept which has become so popular after COVID-19 because of the association of little reduced COVID-19 incidence and mortality with BCG, with OPV, rotavirus vaccines, and many of the live vaccines. So as of now, what we can say is that influenza vaccine will not do anything to COVID. It will not reduce the incidence nor reduce the severity. Influenza vaccines will prevent influenza. And because both the illnesses are occurring during the same time frame, and we are now heading in the monsoon period where we are going to see a lot of influenza, probably it is worthwhile vaccinating.
One more question to you only, sir. Considering overall situation of COVID positivity as well as vaccination, what's your opinion on reopening of schools? According to you, which is the right time to open the school?
See, I think here we should remember that school outbreaks, at least in USA, have not been very common. There have been reports from Israel and European countries where there have been outbreaks from schools. So the picture is not very clear whether reopening of schools are going to lead to an increase in the number of cases because of transmission with the schools. Generally, as I presented in my slides, opinion is more in favor that children are not drivers of transmission like influenza. But we are not certain about it. So from this point of view, considering the fact that most of the time the children get infected from adults, if we can immunize a significant portion of our adult population, maybe 50% or 60%, then we can consider opening schools, reopening schools, because then transmission from adults to children will not occur. Okay, believe me, the way we are going on in our country, I think it's going to be a pretty long time before children can get vaccinated. Yes, Covaxin is going to complete the trials by this end of the year. The data will be ready by then. And if the data is favorable, maybe children may get it. But the prioritization will be for groups who are going to, have demands on the healthcare facility who may die because of COVID. So the priority will be for them. At least this is my personal opinion.
The question is to Dr. Dinesh, sir.
I don't think will occur even in this particular year.
Okay. And one question to Dr. Dinesh, sir. What is the risk of perinatal transmission to newborn?
Yes, see, as I mentioned in my slide, see the risk of vertical transmission is very less. Now, in the perinatal transmission, what we have found from the different registries that those who have screened everyone, including asymptomatic mothers, pregnant women, and everyone, they reported a rate anywhere between 2.4% to 3%. Whereas those who have done selective screening, like those who have done only symptomatic mother screening, another thing, they reported as high 8 to 10%. So I think it depends upon the population whom have screening. So if you look at different countries registered, that's what I found. The report has been as low as reported as 2.4% to some countries reporting 8%. But I feel it is more related to screening symptomatic mothers or you are screening sort of, asymptomatic. What we generally found that those mothers who are sicker, their babies tend to seem to be more positive. That's what has been our observation. That's why even in our study, we found that nearly 10% of the babies turned out to be positive.
And last question of the day, sir. When is this pandemic going to end?
$1 million.
To all the speakers,
You need to get one Jyotishi Baba to answer that question.
See, I think most of the time we have been comparing it to the influenza pandemic. Please remember, the RO of SARS-CoV-2 is 2.5 times that of influenza. So you cannot extrapolate what happened during the influenza pandemic. We are going to have subsequent waves. Remember, the subsequent waves are going to be milder because if it becomes more severe, it's a disadvantage to the virus. The virus mutates because it wants to survive in the environment. If it kills all the host population, it cannot survive. So we are going to have more transmissible, but less pathogenic strains coming. And once the entire population becomes, or a vast majority becomes immune, either because of vaccination or because of disease, then it may become a low-level endemic disease. How many years? As he said, only astrologer can say that.
By this, we come to end of this webinar session. I request Dr. Lakshmikant, sir, President of Hasan IAP, to speak few words. Dr. Lakshmikant,
vote of thanks.
Yeah, vote of thanks. Yes. Dr. Lakshmikant?
Yeah. Am I audible? Yeah.
Yes, you are. Please go ahead.
Last, we have come to end of this webinar program. So, lastly, word of thanks. So, we have to thank all those responsible for a wonderful section of this webinar. First of all, I would like to thank all the IAP dignitaries, Dr. Basuraj GV, Honorary Secretary, Central IAP, Dr. Ashok Datar sir, President of Karnataka chapter, and Dr. Kotturesh, the President of NNF Karnataka, for having given their introductory remarks, also for their encouraging words in conducting this program. Thank you, all of them. Next, I would like to thank all the galaxy of speakers. We had very good esteemed speakers today. First of all, I would like to thank Dr. Santosh Soans for relieving all our apprehensions about COVID-19 infections in children and neonates. Next, I would like to thank Dr. Balasubramaniam sir from Chennai for sharing his experiences in treating COVID-19 infections in children. And it was a wonderful talk. Thank you very much, sir. Next, I would like to thank Dr. Praveen Kilnani, sir, from Delhi. Praveen Kilnani, of course, very well known with all our IAP members. Thank you for sharing your experiences in treating multi-inflammatory syndromes in children. Thank you, sir. Next, I would like to thank Dr. Dinesh Chirla for having spoken on challenges in treating neonatal COVID-19 in neonates. Thank you very much, sir. And also, I would like to thank Dr. Praveen Venkatagiri for enlightening us on the roles of steroids and remdesivir in treatment of pediatric COVID cases. Thank you, sir. Next, I would like to thank our senior pediatrician, our own IAP member, Dr. S.D. Kashi, sir. Thank you for your wonderful remarks on updating our knowledge on pediatric vaccinations. So I think it would be wrong. It would be wrong if I don't thank our own members. I personally thank Dr. S.R. Kumar, Dr. Sudhir Bangalore for taking all this pain in organizing this webinar. Thank you. Thank our DG Prasanna Kumar, Professor and Head of the Department of Pediatrics, HIMSS, and also organizing chairman of this webinar for guiding us through this program. I also thank Dr. Manu Prakash and Dr. Srinivas for all their support. I thank all the members of Indian Academy of Pediatrics of Hassan District Branch and all the pediatricians. I heard from Sudhir, almost 250 pediatricians. 250. So I thank all of them for participating in this webinar program and also for encouraging our works. So thank you once again. I thank one and all.
Sponsors.
Okay. I thank the sponsors of this program. The
Alembic
Pharma, the makers of Brozit, LS, Vicoril, and ZDX. Only one sponsor?
Yeah.
Thank you.
Thank you. Thank you,
one and all, please.
Thank you. Sir, thank you very much.
Thank you.
Thank you very much, sir. Thank you.
Recording stopped.
Thank you, sir. Thank you, everyone.